Good evening, friends. It's fabulous on a Friday evening to see so many of you turn up and, like good athletes, turn up on time. Thank you. Thank you very much for that. So we've got a room full of runners, swimmers, cyclists, triathletes, doctors who treat runners, swimmers, Olympians, ex-Olympians, people who treat Olympians. We've got in the audience, I think I saw ophthalmologists, cardiologists, orthopedic doctors. We've got people with heart transplants. So it's really a very, very mixed bag. So thank you all of you for being here. And without further ado, let me invite Dr. Tarang Gianchandani, who's the Group CEO of Reliance Foundation Initiatives and the CEO of our hospital as well, to give you a formal introduction note. Dr. Tarang, please.
Thank you, Dr. Aashish, for having me here. And I can just say a very big warm welcome to all the people who love fitness, who like to be fit, and who would want others to be also fit. So that summarizes the introduction to all of you lovely ladies and gentlemen, our esteemed visitors who have come from England, and our healthcare professionals and many of our colleagues who are here today. A very, very warm welcome to all of you. It's indeed a pleasure to welcome you all to this holistic symposium, which is a gathering aimed to foster the collaborations and also share the knowledge that benefits both the medical side and also the active communities in the city and beyond. I'm indeed thrilled to see such a brilliant response to this, one of its own kind symposium that is happening today. It's indeed important for us that whenever we embark on something which is related to our well-being and fitness, we should have the best of the people also to be there to advise us, to take us through, to lead us. And with that, I would like to specially welcome our friends from Cleveland Clinic, London, represented by Dr. Sanjay Sharma and Dr. Mark. A very warm welcome to Sir H. and Reliance Foundation Hospital. Both Dr. Mark and Dr. Sharma are world-renowned specialists whose work has had a profound impact on the sports cardiology and sports medicine fields respectively. At Sir H. and Reliance Foundation Hospital, we take a pride in our role as a trusted service provider within the greater Mumbai community. Our focus extends beyond treating diseases, beyond treating injuries, and beyond treating any of the illnesses. We are committed to ensure that we improve the well-being of the society and promote an active, healthy lifestyle amongst the Mumbai population. The fact that you are all present here, I think we have gone beyond the Mumbai population, as I'm told that many of you have come from outside Maharashtra also for being a part of this symposium. It's indeed our pleasure to have you all here, but I can always assure you at the end of the session, you all will come out with new fitness goals and new goals to ensure that you are well and also your families are well. And that's the way we move ahead. We not only make sure that we are fit, our families are fit and healthy, but we also ensure that the society we stay in, the country we stay in, is fit and well. Our Center of Excellence of Rehab and Sports Medicine is privileged to work with many of the Indian Olympic contingent in preparation for the upcoming Paris 2024 Games. In fact, over the past 8 years, we have been providing holistic support for over 40 Olympic hopefuls through our Reliance Foundation Youth Sports Initiative, and are pleased to see a number of these athletes either having already qualified or close to doing so, bringing India the Olympic glory. And it has also helped us in more than a small way to support the initiatives of our chairperson, Srimati Neeta Ambani, who is also a member of the IOC and also has always worked to harness the sport talent in our country and also the well-being of the sportsmen in our country. Our country is on a mission to get healthier and fitter, and Indians everywhere are getting more active and participating in sports events in large numbers than ever before. At the same time, in the recent past, we all have read in newspapers, we all have read on the medias that many of the people have lost their lives during training, during regular exercises, during any sports event. So I think, as I said before, it's not only that we have to work towards staying fit, we also have to work towards staying fit in the right way, so that it's not of any safety issues to the lives of the people who do the trainings. And how do you ensure that is something that I would encourage you all to ponder upon today in this symposium, learn from the experts, ask questions, discuss, and at the end of it, come out with something which is of benefit to all of us and ensures that not only we are fit, we are well, but we are also safe and we know how to do things safely. We should not miss some warnings. We should not just think that, oh, if I'm fit, I can run. That means I'm never at a threat of getting anything serious. I think that's the most important thing, because the perception of people is, oh, I go to the gym, my weight is within the BMI, fine. That means I'm foolproof. I can never have any other problem. And I think when that overconfidence sets in inside us is the time when we need to hear our experts, we need to understand ourselves, because everybody's body is different. So I think this is the time and this is the place where we have to think about all these things and come out with something which will help us for future. So thank you all once again for being here on this lovely platform, and I would also look forward to all the inspiring discussions that will happen here and all the collaborations which will come out to have something more interesting in future and times to come, because well-being is a continuous journey. We cannot say that we attended one symposium or we sat in a workshop or read a book and that's it. It's the beginning of it and not the end of it. So let's embark on this journey together of well-being for all of us here and beyond here. So once again, thank you, and once again, welcome you all to this interesting symposium. I can already see our auditorium is completely full. So we have kept aside the other two rooms also, because this, whatever we have a discussion here, can also be broadcasted there. So thank you very much. Thank you, Dr. Aashish and the entire department to organize this. It is very, very important. And thank you very much.
Thank you so much, Dr. Tarang, and thank you for always supporting our initiatives. I'd like to welcome Miss Deepika Grandhi on stage on behalf of the Cleveland Clinic London to say a few words and get the proceedings going as well. Thank you.
Thank you, Dr. Aashish. A very good evening to everybody. My name is Deepika Grandhi. I'm the representative for Cleveland Clinic in India and head the business development team. A very warm welcome to all the guests here. My first thanks to Dr. Tarang and her team for her incredible support in organizing this event and making it happen, particularly Dr. Aashish, Dr. Chris, Dr. Twisha, the marketing team, Aditya, I don't want to forget any names, Yasha, and Mr. Prasad. Sincere, heartfelt thank you to all of you. Without further ado, I'd like to introduce our first speaker for the session, Dr. Mark Gillet. Dr. Mark Gillet is a consultant sports physician at Cleveland Clinic London. He's an honorary professor of high performance sports medicine. Dr. Mark was appointed as a medical advisor to the English Premier League in 2018 after a decade of experience as a team physician and performance director in that league. Among his many important roles, he was the first team doctor at Chelsea Football Club before moving to his WMA Football Club and then Nottingham Football Club. He was the Chief Medical Officer to the men's and women's basketball squads. He has been instrumental in the Department of Pre-Hospital Care and Training, which was visible during a high-profile casualty in the Premier League during the last session. Without no further ado, now I would like to welcome Dr. Mark to the stage. The floor is all yours, Dr. Mark.
Well, good evening, everyone, and thank you for the invitation to come and speak to you. It's an immense privilege for myself personally and for Cleveland Clinic to be given this opportunity. So, I'm going to break this down into two elements. We're going to talk about exercise medicine to start with, and then we're going to move on to musculoskeletal medicine, and we're going to talk about my approach to both areas of my work, with particular emphasis on what we can learn from high performance sports and how we can apply this to patients in another setting. So, a little bit about my career journey. My interest in sports started, so I was a teenage swimmer, a reasonable athlete, reached quite a high level of attainment in that sport, captain of university, and then I went on to train in emergency medicine and sports and exercise medicine, and I was a full-on emergency medicine consultant for 4 years from 2004 to 2008. I did my time in Olympic sports, so I was one of the first doctors appointed to the English Institute of Sport in 2003, and followed that through onto the 2012 Olympics, where I was working with basketballers, head of athletic performance. It was almost my intention to get into football, and I was lucky enough in 2008 to be appointed first team doctor at Chelsea. I did that for 2 years. And then I went to another team in the Premier League, and I think probably importantly and uniquely, I was then the dual role of performance director and team doctor, which I think has influenced a lot of what I've done since. All good things come to an end, and that happened in 2019 when I became Chief Medical Officer of the Premier League, and then good things happened, and I became one of the first consultants at Cleveland Clinic London in 2021. So, a few simple things about my philosophy with patients. I'm pretty old-fashioned. The history is everything. So, there's not many times where I get up from my desk not having a pretty good idea what the diagnosis is. So, I'm very specific about the questions I ask patients. At times when doctors in training are in a real rush to learn ultrasound and how to use diagnostics, my hands are my most valuable tool. I've been using them as a doctor for nearly 30 years. Don't throw out what you've acquired and what you've learned over a number of times because of new technologies. My hands really are my most valuable diagnostic. Something I think is really important: treat the patient, not a joint or a muscle. So if you're telling a patient to give up running because of their knee, think about how that affects them as a person, because it might not be the right thing to do, and often isn't in my experience. And then finally, meaningful habit change is the key to success, and we'll talk a little bit about that as we go through the talk. So let's talk about exercise. In football, in the Premier League, every movement is measured, analysed and controlled or prescribed. So data is individualised, and then it's analysed by a professional with recommendations applied to the context of the job. So what we recommend for a 24-year-old right back might be very, very different to what we recommend for a 33-year-old goalkeeper. So this is very typical of the training readout that we get following a training session in a Premier League training session. So this is a catapult system, which is a mixture of accelerometry and GPS coordinates. And we have a variety of metrics which allow us to monitor how we run training that week, with a number of individualised ceiling requirements for each player. So it's very, very specific. On match day, different technology, so camera-based technology, but you can see we're getting a whole load of data and metrics for everything that we're asking that player to do during a Premier League football game. So how do we apply these principles when we're talking about patients who aren't professional athletes? Well, you've got to remember it's not their job that we're talking about. So other aspects of their life are going to create pressure on their time, and are more important, family and work, so be sympathetic towards that. I think this is something that has really grown over the last few years. So patients can be led by commercial data, Whoop or Apple, which is algorithm-based and very, very generalised. And patients often put too much pressure on themselves to comply with that data. You often find that that leads to common sense being ignored and the data inferring a different action. So how do you tackle it? What common issues and battles do we have? Well, probably the commonest problem that I have in clinic is poor periodisation of training, with the basic principles of load and recovery completely ignored. How many runners do we have in the audience? There we go. So middle-aged runners, so people who have come to running in middle age but not from a running background, are usually the worst offenders of that. They want to run long and slow every time, no variation in training stimulus. It'll only lead to you getting injured. The other cohort I see that in is in young females with high-intensity training classes. So I've got a cohort of patients at Cleveland in London who have had femoral neck stress fractures and required metal work putting in their hips, largely again because they're going at high-intensity training all the time with very little recovery and leading themselves to get injured. The quality of life that we've mentioned can often be diminished from information from wearables, sleep especially. So the number of times that you'll be sitting there waiting to go out on a ride, I've sat next to people and they've said, I woke up this morning feeling really good. And then I looked at my Whoop. My Whoop says that I haven't had enough REM sleep and I feel really terrible since then. But that is a very, very common problem about patients really translating what they're seeing from a wearable into their everyday life. So good exercise advice is very hard to find. And in the UK, certainly GPs and swimming are a common offender. So how many people in the audience feel that swimming is a good exercise? Anybody? Any reason why that might be? So the problem is, it's not load bearing, so it doesn't help the joints. Most people are technically such poor swimmers that they can't get their heart rate up long enough to burn any calories. So that if somebody's taking on swimming as an activity to lose weight, generally they end up very disappointed, they become demotivated, they give up exercise, and you don't see it for 12 months. So be careful how you use swimming, because generally it's not a great exercise for people who want to start exercising. Point 5, patients are very focused on stretching and often ignore strength, and that is a big, big problem. And then another thing that I think even government officials in the UK that I've dealt with, differentiating between activity and exercise, so they're not the same thing. Activity is when you break up your day to use the stairs, you get up off your chair to move around, very, very important. But it's very different from exercising at 75% of your maximum heart rate, going to the gym, loading appropriately. It's very, very different. So don't confuse the two. Solutions. So number 1, understand recovery. I think that is really, really important. Not many people outside of professional sport understand recovery. Work-rest ratios in different training zones are really, really important. And using a heart rate monitor with a chest strap rather than a wrist strap, very important. So if a patient says to you, I'm doing a lot of high intensity training, I'm doing 2-minute intervals, what do you think about that? They're not doing any high intensity training at all, because if you're managing it for 2 minutes, it takes a lot of recovery. So patients don't really understand their real exercise thresholds, and that's a real problem, and educating them about that is really important. I ask this question in clinic probably about 10 times a week to people who are trying to get to exercise. So people are very busy or doing whatever else. And the question I ask themselves is, in your busiest week, what amount of time can you commit to exercise? And if they say 10 minutes 3 times a week, that's something to work on. And the reason I do that is because 10 minutes 3 times a week every week is beneficial. And even if you're Elon Musk or you're Prime Minister of the UK or President of the US, you can find 10 minutes 3 times a week. So everybody can do that. If they don't want to do that, they don't want to exercise. So it's a very useful discriminator. Something else in terms of, and we've been through this evening, that I think is a really important area to start with strength work. So squatting is a really important exercise. but squat with good form, do it in a sit to stand range, so you don't need to deep squat, and do it with a good load. And that is a starting point for pretty much any strength program. And don't do too much too quickly or all at the same time, because you're going to end up failing. So, patient A, 62-year-old male, initially reviewed by me with minor knee degenerative changes, and now wants to lose 5 kilograms and get fitter. So 4 points. He's just moved house in a new area. He has a gym at home with a long-standing PT. He likes food, by his own admission, and he works long hours. So where do you start with that? Is there a red flag you can see in those 4 points? How do you start with that? Well, the answer is he has a gym at home with a long-standing PT. So he's come to see me because he wants to lose weight. He's rich enough to have a gym at home, and he's got a long-standing PT. So the gym program's not working for him, and the PT he's working with is allowing him to do a gym program that's not working for him. So you've got to tackle that difficult social problem before you go any further. So, there's a little bit of so that's why the questions, the history is really, really important. So, what do we do with him? Phase 1, lose weight and be active, right? So intermittent fasting, 3 to 4 days a week, normal the rest of the week. So intermittent fasting is his activity, yeah? The advice then is to enjoy the type of activity that makes you feel good. Last thing you want to do if you're intermittent fasting is for somebody to tell you need to get on a watt bike or an exercise bike for half an hour at high intensity and turn something which is difficult enough into something that's impossible. So a little bit of common sense. When they've done that, and when you've lost the initial amount of weight and you've committed to that, you've proved you committed to that, then you go into phase 2, which is exercise and strength. Strength, increasing lean body mass, and combating sarcopenia, which is an increasing problem. Anaerobic activities, again, heart rate control with a chest strap, high intensity training, helpful, but work-rest ratios are really, really important. So that basic education, so how exercising can be effective for them, so very specific advice. Then phase 3, which is often the difficult bit, you reach your end of your 8 to 12 week initial period. How do you maintain it? What sort of long-term habit change do you need to make that a realistic change for life? What are the realistic long-term goals? And how do you incorporate happiness and well-being into that? Because I think that's really important. So far he's doing really well. So we come on to musculoskeletal medicine next. So my philosophy with patients, I've got 2 tasks. I've got to get them out of pain, and then I've got to keep them out of pain. And the 2 often don't go in sequence, and they often don't go hand in hand. So if we're going to get them out of pain, normally that means exercise rehabilitation, surgery, or an injection. And keeping them out of pain is always about exercise rehabilitation and changing habits. But you can't be too theoretical about it. So you can't leave a patient in pain. So if you go and see a knee surgeon and you've got knee arthritis, which is not quite bad enough for a knee replacement, a total knee replacement, it's not acceptable to say to them, just get on with it until you need a replacement. And that is an opinion I see so many times, it's not good. So you've got to do something more than that. You've got to offer more than that. At the same time, if you're a physio and you're doing the right type of rehab, but the patient is in too much pain to do that rehab and make straight gains from that rehab, you've got to change their pain, because otherwise they're not going to get to where they need to be. So you have to think very practically about that. So what do I inject? So I inject steroid. I'm a fan of steroid, and the reason I'm a fan of it is because it's reliable. And I always use it as an agent to unlock rehab. So if you're just using it as a standalone treatment, it's a very bad treatment. If you're using it to empower a patient to go and do their rehab, it's very, very effective, and it's a reliable outcome, and it's very inexpensive. The other thing I make is that you need a reliable outcome sometimes to gain the patient's confidence, so they improve their confidence, and also they have more confidence in you. So if you're using something which is less certain, such as BRB, even though there might be reasons why you're doing that, Sometimes if it doesn't have the desired effect, the patient's confidence in you is diminished, and you can't perform and do what you need to do. And as we all know, steroids, first is the best one. After that, it's diminishing returns. I also inject BRB increasingly. The evidence is very mixed. We can have the really confidence there and spend the first half of people telling how good BRB and the next half from both the good research on both sides how rubbish it is. So, again, it's very practitioner dependent. It's a biological anti-inflammatory and it works pretty well. Certainly with actually BRB combination, when we put that into joints, that works pretty well. So also, a number of neuroinjections we do at the Cleveland Clinic London. We want to be the #1 unit in Europe for reviewing and testing new joint injectables. So that's a clear aspiration for us. And I think we're on the way to do that. So I'll tell you a bit about Ophoresin, which is a treatment you may not know about. So this is injectable hydrogel. It comes in 6 syringes. Been used in Scandinavia for a long time. Been used in the UK for about 3 years, and the results are pretty promising. So it's 2.5% polyacrylamide and 0.5% water. And it's incorporated into the synovium so that you have a barrier in the joint, and that's how it works. To show you there, so exactly what it does. It's taken up into the synovial lining, and it works really, really well. Again, there are a lot of competing evidence, or a lot of evidence on this. This is a study on which is only 49 knees, which was injected over the course of a few months. Now, the idea of Ophoresin is that it gives you 3 years relief up to 3 years relief from significant pain from arthritis, which is obviously a lot better than some of the other competitors that we use. After 26 weeks, there's a 20-point decrease in weight loss scores, so I think that's really impressive. It's up a little bit at 12 months to 18 points. It's still very, very effective, and certainly, I believe it's probably the best on the market at the moment for reducing pain in arthritis of the knee. Just talking a little bit about exercise rehab. So one of my mandates, along with people talking about swimming and various other things, when people come in to you, I've had physio. So, physio is one entity, not subject to quality deviation or changes in innovation. And I think one thing that I take forward to the patient is something I call the rehab matrix. And that is remembering that initially we get the gym, we make sure you're strong and stable, and you've got the tools, musculoskeletal to the class and the algorithm. And then we get you into linear activity. So, that includes running. So running is a linear activity which is relatively easy to rehabilitate into. Biking and cross trainer and that type of work. Finally, to multi-directional activity. So tennis, martial arts, any form of running. So those place huge demands on the joints, and those are ones that are challenging to rehabilitate into. And when you think about how you put together an exercise rehab program, it's control versus anything else. So rehab is all about control. Frequency, mass, direction, speed and volume. All of that is controlled. And then gradually you the case and the uncontrolled part of it, which is you drip feed the unpredictability of your design activity in, and then you rehabilitate them back into that activity. And another thing, briefly on mechanics, very, very simple concepts, particularly with runners, particularly with people with tendinopathy, is that they're very, very simple. When you want to land on your leg, you want your glute to be pulling your glutes to be pulling your hips laterally, and then you want your glutes to be pulling your knee immediately, so that you have a really stable zip cord effect when you need over a big toe. You need an effective range of weight bearing tools and function. Yep. Effective weight range and weight bearing dorsal function and a good range of subtalar duty, you can rock and roll. If you obey those 4 points, you're not going to go far wrong. So they're pretty crucial for any anterior chain that you're going to do. So, basically, 21-year-old male, increasing rate of pain, hemorrhage, mitochondrial changes to his patella, being on a single leg squat, knee dominant squat. What does he want to get back to? He wants to walk his dog, and he played football actually till age 35. Any ideas how to start with this patient? After what I just said, what would I do first? I'd inject his knee because I need to move him out of pain, so I need to get rid of his pain so I can keep him out of pain. So inject his knee, relieve his pain, increase his confidence in himself and myself. Get him walking his dog, and that's what he wants to enjoy, and that's what we're going to get him back to. And that's a great place to start. Then we get him into exercise rehabilitation. Yeah, that's pretty good. Squat, sit to stand range, good technique, high load, all those things are really, really important. And don't be in a rush to introduce single leg activity. Generally, patients are way too unstable to improve their strength on a single leg, so getting doing everything on double legs, certainly in the initial stages. And then discuss and agree long-term exercise goals with them. So very, very important. And these patients do well. So some of the exciting things we get to at Cleveland Clinic to finish. So part of my role at Cleveland is that I'm the pitchside lead for the NFL against London, so the NFL London series. So let's watch this through. And watch this guy. Watch his left leg. Any ideas what happened? Okay, so this is the thing that followed. Can anybody spot me on there? The only one walking off the pitch with the phone in his hand, so that's the position I like to be. I let the others get on with the retrieval process, and this is what his x-rays look like. Yeah. So how would you describe that on the telephone? Yeah, that's what you're literally. Yeah, exactly. So it's a multi-part tibia fracture, and it's open, so that's what it looked like. So it's an open wound, open fracture. All right, so, and interestingly, so in terms of planning for that game, the endpoint that we've been planning for was an open fracture of the tibia, and we got one within 10 minutes, and they hadn't had one in the NFL for about 10 years. So how's your sorry. So these was x-rays, so two-stage procedure. So there was a plastic surgeon and orthopedic surgeon on call from Cleveland Clinic, London, and he was in theatre at Cleveland within 3 hours of the incident. External fixation on, plastic surgeon dealt with the wounds, and then 3 days later he had his nail put in. But weren't that long. Post-op week 2, that's what he looked like. So his legs looked pretty good. And this is what he was like in 6 weeks. Horrible injuries, full weight bearing. Anybody recognise the player? Any American football fans? Post up 2 months, post up 3 months, all looking good. And then 6 months later, this is the reward you get. I'll see it from another angle. Apologies for the drill music for these Americans, so we'll let that go. And then final. So from having that injury at Wembley, or at Tottenham rather, at the beginning of October, he went back into camp in March, April time and played a full season the following season, so he did really, really well. So That's our building in London, and that's the surgeon who repaired his ankle, to show you some of the exciting things we're doing collaboratively at Cleveland. Great place to be a part of, and thank you for your attention, and thank you to my clinical fellow for putting this presentation together for me. Thank you very much.
So it's my great pleasure now to introduce Dr. Professor Sanjay Sharma, who's Professor of Cardiology at the Cleveland Clinic, London, and St. George's University of London and St. George's NHS Foundation Trust. His interests lie in heart muscle disease, sudden cardiac death in the young, sports cardiology, for which he's had more than 350 publications in some of the best journals in the world. He is the director of the largest sports cardiology unit in the UK, which is responsible for athletes with potentially serious cardiac diseases in the English Football Association, the Rugby League, the Lawn Tennis Association, and the English Institute of Sport. He is the cardiology advisor for the British rowing team and the chairman for the Expert Cardiac Committee for the Football Association. He is the medical director of the London Marathon and has been commended for providing the best services for it. He is awarded membership of the Venerable Order of St. John for his service to St. John's Ambulance and for supporting medical welfare of runners. He was the lead cardiologist for the 2012 London Olympics and provided medical services for all endurance sports. In short, Professor Sharma is the first word and the last word in sports cardiology. He has written the textbook on the subject, literally, and I've had the pleasure of hearing him speak at various conferences and interacting with him now since about 10 years. And like I said, let's not keep any distance between you and Professor Sharma. Sir, the floor is all yours.
Firstly, thank you very much for inviting me. It's a real honour to be here representing Cleveland and to be speaking at such an amazing institute, the Reliance Hospital. We talked about the benefits of exercise, and I'm going to stick with that theme, but I'm also going to bring into the concept that sometimes exercise can trigger serious problems. So I'm going to talk about differentiating the fabulously fit from the fatally flawed. So let's start by talking about the benefits of exercise. I think we'll all agree that the benefits of exercise on the cardiovascular system are very well established. People who exercise regularly are less likely to be overweight and therefore less likely to have insulin resistance and diabetes. They're more likely to have a better blood pressure and lipid profile. And through curbing all of these risk factors for atherosclerosis, people who exercise regularly reduce their risk of an adverse cardiac event by around 50% when they're in their 5th, 6th, and 7th decade. But if we actually look at the actual benefit that exercise has on these atherosclerotic risk factors, you will see that it's relatively modest. Exercise reduces your systolic blood pressure by around 5 millimeters of mercury, brings your diastolic blood pressure down by about 3 millimeters of mercury, brings your total cholesterol down by about 5%, your LDL cholesterol by -2%, and only brings your body mass index down by -1.3%. So although it does curb risk factors for atherosclerosis, exercise does lots of other things. And it does this by increasing cardiac size, improving myocardial relaxation, allowing one to augment stroke volume so there is good tissue perfusion. It reduces aortic stiffness, improves left ventricular compliance, increases plaque stability. In the periphery, it increases capillary conductance, it increases oxidative capacity, reduces thrombogenic stress. At the electrical level, it reduces heart rate and stabilizes the cardiac membrane. And overall, it reduces systemic inflammation. And through the constellation of all of these functional changes, what exercise does is improve fitness, which is best measured by the peak oxygen consumption. Now, no one will argue that the peak oxygen consumption is the best objective marker of longevity. So people who exercise regularly live around 7 years more than people who don't exercise, and there is nothing that we have invented in medicine thus far that gives you 7 years of life there is no pill that gives you 7 years of life or any operation in someone who's ostensibly got not much wrong with them. So to get those benefits, I want to add a little bit more. The WHO tells you that you should be doing 150 minutes of physical activity. Now, Mark made it very clear that physical activity is different from systematic exercise. But I'm going to promote physical activity to start with. So if it means you're walking instead of getting on a bus or getting into a car, if you're going up and down stairs instead of taking lifts, you should be doing 150 minutes of that divided by 5 at the very, very minimum, okay? But the sweet spot is you need to be doing 4 times that. You need to be doing 600 minutes of physical activity per week to reduce your risk of ischemic stroke, heart attack, diabetes, and several malignancies. Let's talk about the exercise paradox. So although you've heard about the benefits of exercise, it's also true that exercise can trigger myocardial infarction and promote fatal arrhythmias. There is also evidence that it may worsen arrhythmic substrates. And by causing sudden death, obviously this sort of thing becomes quite a big deal, because an exercising person who dies or nearly dies, this sort of event is very counterintuitive. You don't expect this to happen, especially when it's potentially associated with loss of decades of life. And when something like this happens, it's very, very heavily publicized by the media and really causes a lot of concern amongst the general public. We saw this in our Premier League, and what Deepika was telling you about earlier about Mark's input into our Premier League. You've got this football player dying, and he's been working on this for years about good pitchside care. Just look at the speed at which the medical team has arrived, and that medical team has arrived prepared. They didn't come with a bucket of water and a sponge. They came on with a defibrillator, thinking that something awful had happened. I'm pleased to say that sudden death in young athletes, when I start with young means under 35, is uncommon. And the incidence of sudden death in young athletes ranges from 1 in 15,000 to 1 in 100,000. And you see this is very, very broad. And that's because death is influenced by demographics of the athlete. The mean age of people that usually die, usually about 18 years old. There's a huge male to female ratio. In elite sport, there's a male to female ratio of 9 to 1. And in recreational sport, there's a male to female ratio of 20 to 1. Maybe not so applicable in India, but deaths are more common in athletes of African or Afro-Caribbean origin than in white individuals, 5 times more. And some sports afford a greater risk, such as soccer and basketball. 80% of these deaths occur during exertion, and a significant proportion of people have no risk factors. So although I'd like to point out that sudden death in sport is uncommon, there are certain groups where it can be relatively common. For example, in our adolescent football players in the Football League, the incidence of sudden death is 1 in 15,000. If you look at a male basketball player in the United States, the incidence of sudden death is around 1 in 4,000. So lots of things govern this. If we look at the causes of death, you'll see that the causes of death are due to a diverse spectrum of cardiovascular diseases, which may have a genetic basis, a congenital basis, or an acquired basis. You will see at the top here that the cardiomyopathies are the leading cause of death. In the United States, hypertrophic cardiomyopathy is the most common cause of death. In Italy, arrhythmogenic right ventricular cardiomyopathy is the most common cause of death, but other causes include congenital anomalous origins of the coronary arteries, aortopathy, sometimes valvular heart disease. In our institute, where we actually conduct expert cardiac pathology in athletes that have died, we've got a data set of about 367 athletes that have died suddenly, young people in whom we've conducted autopsy. We actually don't find a cause in 40%. So in 40%, the post-mortem is completely normal. But if we go back then and screen their parents and their siblings, we find an underlying genetic electrical fault in around 40% of those people. The prevalence of these diseases in the young athletic population is around 0.3%. So 1 in 300 young people, certainly in the Western world, have a cardiac condition that could potentially kill them. If you've got one of these conditions and you exercise regularly, you are 3 to 5 times at a greater risk of a sudden death compared to someone who doesn't exercise. So here's a situation where exercise may trigger a sudden death. So apart from the actual substrate that the patient's got, if you super add upon that the stresses of exercise, such as dehydration, adrenergic surges, electrolyte imbalances, you can see that someone may go into ventricular fibrillation. I'd like to emphasize again, this is not a license not to exercise. Everyone should be exercising. What I'm trying to tell you is that if you've got an underlying cardiac condition and it's quite severe and you push yourself very hard, you may put yourself at risk. Clearly, these deaths occur in young people. They occur due to diseases that can be diagnosed, for which there are many treatments, including pills, ablations, operations, implantation of a cardioverter defibrillator. So there are multiple incentives of identifying some of these athletes, particularly in elite sport. But clearly, if you're going to be identifying athletes with serious disease, you need to understand the impact of exercise on the heart itself. Whilst you're sitting down at the moment, you're pumping 5 litres of blood around the body. But if you're out there playing cricket or kabaddi or something like that, between wickets and during active kabaddi, that cardiac output goes up to 30 litres per minute. So the heart has to adapt to allow you to do that. So with exercise, the heart undergoes a constellation of structural and functional changes which are then manifest on the athlete's ECG. And these structural changes include an increase in wall thickness and chamber size. Functional changes include enhanced diastolic function, augmentation of stroke volume at high heart rates, and a high peak oxygen consumption. And electrically, the heart shows increased vagal tone and voltage criteria for chamber enlargement. So this is the ECG of a Team GB gold medalist, showing sinus bradycardia, right axis deviation, voltage criterion for left ventricular hypertrophy, incomplete right bundle branch block, which is a marker of right ventricular overload, and the early repolarization pattern. Now you can imagine if this young man pitched up to a primary care physician who didn't understand this, they would deem this ECG as abnormal. So these athletes need to be tested by experts who actually know what they do, and that's, I think, one thing we're very proud of in Cleveland, that we do cater for a lot of our athletes and a lot of football teams that come to see us and get assessed by us. In terms of the athlete's heart, there's a 10 to 20% increase in wall thickness, a 10% increase in left and right ventricular cavity size, which amounts to about a 45% increase in left ventricular mass. However, the magnitude with which these physiological changes manifest in an athlete is governed by several factors, including the age, the sex, the ethnicity, the type of sport, and the intensity of exercise that the athlete is engaging in. Here is a bar chart showing you the distribution of left ventricular cavity dimensions in over 1,000 Italian Olympiad athletes. The blue bars are the males and the red bars are the females. You see that the blue bars are shifting towards the right. Men are generally taller, they've got bigger muscle bulk, they've got longer bones, they've got longer tendons. So in general, pound for pound, they outperform women. That's something that's well known. So as a result of that, they get bigger dimensions. The second thing I want to point out is that 48% of athletes have a left ventricular cavity dimension that is greater than that of the general population, and 14% have a left ventricular cavity size that's 60 millimeters or more, which may overlap with a condition called dilated cardiomyopathy. And these are usually adult males engaging in large adult males engaging in endurance sports such as long distance running, long distance cycling, and triathlons. These are the sort of people that get very big dimensions. We also see that in rowing and canoeing in the UK. Here is a bar chart comparing wall thickness in males and females. And if I said to you that the upper limit of normal is 12 millimeters, you'll see that unlike the LV cavity size, very few athletes actually achieve a wall thickness of more than 12. And when you do see it, it's only the blue bars. You only see it in males. we don't see left ventricular hypertrophy defined as a wall thickness of more than 12 in women. And when we see it in men, in white men, we only see it in 2% of white men, not more than that. Even if you look at the geometry, we find that most athletes have normal geometry, but when we look at concentric remodeling or concentric hypertrophy, it's more common in males and females. So the take-home message is that females, when they do get hypertrophy, is from increased LV cavity size, not from increased in wall thickness. Again, maybe not so applicable to you in India, but if I was giving a global talk, I think we'll all agree that the Africans and the Afro-Caribbeans contribute very heavily to global sport and really do win lots of medals. And they make up 30% of our elite athletes. So here we've got black athletes in the red bars and the white athletes in the blue bars, and we're showing you the distribution of wall thickness measurements. I've already told you earlier that LVH of more than 12 is only found in around 2% of our white males. But look at this, it's found in 13% of our black athletes. But no matter what the ethnicity, whether it's white, black, Asian, we never see wall thickness measurements of more than 15 millimeters in males. If you do, you're dealing with pathological left ventricular hypertrophy. Even when we look at the ECG, blue bars are the black athletes, the red bars are the white athletes. Black athletes generally have a higher prevalence of ECG changes that we consider either abnormal or borderline. I'd like to focus on T-wave inversion. Here is Mo Farah's ECG through permission, of course. This is an ECG that was taken just before the London 2012, where he clearly had a syncopal episode that was vasovagal. He felt lightheaded, he'd done a very heavy training session, felt a bit queasy, went down for seconds and was fine again. And I was asked, do you think this guy can participate in the London 2012? Just imagine the pressure on a sports cardiologist. Had we said no, it would have cost us 2 gold medals, right? We won the 5,000 and the 10,000. But this ECG, I agree that if this chap was clutching his chest outside this hospital here, they'd be in the cath lab and you would be doing an angioplasty to the left anterior descending artery. Because what it shows is J-point elevation with convex ST segments in V2, V3, V4 with deep T-wave inversion. But this ECG pattern is found in 12% of black male athletes. We've investigated this in a lot of detail. We've followed these people up for years. We've done MRIs on them. We've done genetic testing on them. We've tested their families. But this pattern, believe it or not, is a benign pattern in black athletes, not in whites though. What about abnormal ECG patterns? You need to understand what normal is, which I've shown you, but what abnormal is. And this, if I was teaching someone, if I was teaching students, the one thing that they should take away from this lecture is this slide. Because these are the international recommendations of how we interpret ECGs in athletes. And these are used globally. They're used by FIFA, they're used by lots of big sporting organizations. In the green are the normals. I've already told you, but increased vagal tone, voltage criterion for LVH, T-wave inversion in V1 to V4 in black athletes, the juvenile ECG pattern in white athletes, in children. And then red are the abnormal ECGs, and I'll come to those. Then you've got the borderline ECG changes. If you've got left or right atrial enlargement, left or right axis deviation, or complete right bundle branch block. If you've just got one of these, you go into the normal category. If you've got 2 of those, you go into the abnormal category. So I'd like to focus on T-wave inversion now. But just to let you know that T-wave inversion generally is abnormal, except for in black athletes and in children. ST segment depression is always abnormal, as are pathological Q waves, complete bundle branch block, left bundle branch block, interventricular conduction defect of more than 140, ventricular pre-excitation, a long QT interval. The definition of a long QT in athletes, QT more than 470 in males, QT more than 480 in females, and of course the Brugada ECG pattern is definitely abnormal. Now here's an ECG that is always abnormal, no matter what the ethnicity of the athlete. What you see here is inferior and lateral T-wave inversion. This ECG is found in 0.5% of white athletes, but in 2.2% of black athletes. Now, if you see an ECG like this, even before you put the patient in the MRI scanner, you can tell a white athlete and an Indian athlete there's a 60% chance I'm going to find a cardiomyopathy or myocardial scar. In a black athlete, that chance is lower, 18%, suggesting that this ECG pattern in black athletes, 2.2%, doesn't have as great a diagnostic yield as in white athletes, which means that in some of these black athletes, it may not mean anything. But you can imagine the pressures on a sport cardiologist, 30, 40 million £40 million purchase, and a club say, well, what do you think? What do you think? What do you think? And they want the answers today. There's no MDT where we sit around, the media waiting, the club wants to make an announcement. So you really have to know a lot, have a lot of contacts, have a lot of supportive colleagues that you can call upon even at 2 a.m. if you have to in this sort of job. What about anterior T-wave inversion? I've told you black athletes get anterior T-wave inversion. I told you children get anterior T-wave inversion. Sometimes endurance athletes may have T-wave inversion in V2 extending to V3. Females often have T-wave inversion in V1 and V2, but some of you in cardiology will be aware that T-wave inversion in the anterior leads is also something that we find in 60% of all individuals with arrhythmogenic right ventricular cardiomyopathy, which is a recognized cause of sudden cardiac death. But remember, in ARVC, the ECG is abnormal in 80%. They don't just get anterior T-wave inversion. They get all sorts of other things, such as a prolonged S-wave in V2, low QRS voltages, epsilon waves, and extrasystoles, which you need to be looking out for. So here's a 17-year-old cyclist. Clearly he's white, he's adult, so the fact he's got T-wave inversion extending this far, V1, V2, V3, V4, tells you it's abnormal. But here you see terminal activation delay. At the top you see an epsilon wave, and you've got small QRS voltages. This athlete was diagnosed with ARVC. What about low QRS voltages? This is not quite the new kid on the block. We've been talking about it for decades, but it's only just, people are just starting to publish it. By low QRS voltages, I mean that the peak of your R to the nadir of your S wave in your limb leads is 5 small squares, i.e. 0.5 millivolts. You find this in 1% of athletes, and if you see this, you should always put your athlete on a treadmill to check for ventricular extrasystoles. There's a particular form of ventricular extrasystole that you see in low QRS voltages, and that ventricular extrasystole conducts with wide right bundle branch block and a superior axis. So if you see an athlete with low QRS voltages, and if you put them on a treadmill, or if you do a 12-lead 24-hour tape and you're seeing these extrasystoles and they're frequent, there's a 1 in 2 chance that you will find a scar affecting the inferior or the basal left ventricular wall. Just told you this. How do you differentiate cardiac adaptation from cardiomyopathy? I've started talking to you a little bit about that. Physiology can sometimes overlap with pathology. And in the UK, we see it in our black athletes in terms of wall thickness, and in our white endurance athletes who do triathlons, rowing, etc. These are guys that have got big ventricles, but at rest the ventricle is very lazy. So the ejection fraction, I wouldn't say very lazy, slightly lazy. Between 48 and 54% the ejection fraction is coming in at. So the question is, on your left, are you dealing with hypertrophic cardiomyopathy? And on your right, are you dealing with dilated cardiomyopathy? Remember that anything I say, and if I'm wrong, I've harmed that athlete. If I tell that athlete you've actually got something wrong with you, I've affected them physically, psychologically, potentially financially, if the club decide they're not going to take that athlete on. If I tell that club, tell that athlete there's actually nothing wrong with you, I've given that athlete and the club false reassurance, which may come back to bite me if this athlete has a sudden cardiac arrest. So again, it's a pressurized job where any error could have a bit of a disaster. But this is how to differentiate between hypertrophic cardiomyopathy and an athlete's heart in an athlete who's got a wall thickness of between 13 and 15 millimeters. Clearly, if someone's got a family history of hypertrophic cardiomyopathy, then you think that they may have the condition. If it's a female or an adolescent, I already told you they don't get LVH of that magnitude. If you see abnormal diastolic function, not a feature of athlete's heart. If you see an abnormal strain pattern, again, not a feature of athlete's heart. Low peak oxygen consumption. Those ECG changes I talked to you about, S2 depression, T-wave inversion, Q waves, left bundle branch block. or if you see scarring on the MRI scan in the hypertrophy segment. Conversely, if it's a male individual who's only got isolated LVH with symmetric hypertrophy, big LV cavity, normal diastolic function, big peak oxygen consumption, that's probably a normal finding. So this is the sort of athlete that we are. We don't see that gross HCM that you're used to seeing. We see very subtle stuff, because if you are able to be a Premier League football player, you won't have severe HCM. You'll have very mild HCM, or it'll be LVH confined to the apex, as you see here. And here you get information not just from the echo, you get information from the ECG or even the MRI scan. See, this guy's got a mild hypertrophy, LV cavity, not big but not small. There's apical cavity obliteration, but look at the ECG. So the ECG gives it away. We've got deep T-wave inversion in V4 to V6, and when you put this person into an MRI scanner, the answer is there. So you don't just rely on the echo, you get information from the ECG and the MRI scan. What about dilated cardiomyopathy versus athlete's heart? Big ventricle, ejection fraction 45 to 55%. Clearly someone's got symptoms or a family history of dilated cardiomyopathy, you worry about pathology. The ECG changes I talked to you about, low peak oxygen consumption or scar. Conversely, if the individual's completely asymptomatic, this is the important thing. You exercise them and you repeat the echo. If the ejection fraction increases to 11% or more, or the peak ejection fraction goes above 63%, that's more likely to represent physiology. So here's a Premier League football player who's got beautiful echo pictures, but they've got a big heart and a slightly low ejection fraction. And you get a report saying, cannot exclude dilated cardiomyopathy. You imagine telling Manchester City something like that, right? Transfer deadline day, 3 days away. And here, what we do, we exercise this individual. His heart wakes up very quickly, ejection fraction goes up to more than 11%, and so forth. Might even do an MRI, but I'd be happy with just this. But clearly, if you've got a funny looking ECG, then you do the MRI scan and you may see scar. So how do we prevent sudden death? Well, we can do lots and lots of tests, but you imagine I'm not just talking about the elites. You could argue that in elites you should be doing all sorts of tests. Even that's difficult to justify, considering that sudden deaths are very uncommon. So if we're going to do this for lots of people, we've got to do the cheapest thing that's easy to do, that's easy to get, so there are no disparities, and that's relatively easy to interpret. Otherwise cost becomes prohibitive. We're then left with history, examination, and the ECG. The history, as I said, 80% of athletes have no warning symptoms before they die. Physical examination rarely helps, whereas Mark's hands help. Our stethoscope in cardiology don't help with the conditions that cause death, which is a pity really, because we are proud of our stethoscopes. The ECG can help, because the ECG will show you abnormal disease in ion channel diseases or pre-excitation, and the ECG is often abnormal in the cardiomyopathies. And we use these international recommendations I've just talked to you about. We've reduced the false positive rate down of ECGs to around 3% in white athletes. We still could do better in black athletes, but we've maintained sensitivity for diagnosing serious disease at 92%. And we've improved specificity from 87% to 97%. And the positive predictive value of an abnormal ECG is 17%. So almost a 1 in 5 chance that you're going to find something serious if that ECG is abnormal. When we tested our 11,000 football players, this is what we found. We found that 7% needed further investigation, and we diagnosed serious disease in 42 of them, 0.38%. These are people that tested with ECG and echo. We picked up congenital valvular disease and septal defects in 2.2%, but we were left with 2.5% in whom we didn't know what to do with, because they had a funny looking ECG, but otherwise everything was okay, or a big heart, but nothing else. So if you did do this at a mass level, you'll be left with 2.5% of athletes. We think we need to keep looking after them. Obviously, every year they'll get bigger and bigger and bigger whilst they're playing. But when we did work out which test performed the best of the cheapest test, the ECG was the best test. So in cardiology, paradoxically, the cheapest test gives you the best yield, which may not be a bad thing when you think that we're going to screen, we should be screening all athletes, not just the not just the Northern Americans and the European ones, but all of the Asian ones, the African ones. And so you should need to be relying on cheaper tools for some of these people. So the strengths of the ECG is that it's cheap, it's readily available, it can pick up electrical and structural disease, and there are several developments which have modified the ECG interpretation, but there are limitations. There's a great deal of inter-observer variability, and so you need to adhere to those international recommendations. It performs less well in black athletes. It cannot detect coronary artery disease. It may not detect incomplete expressions of cardiomyopathy or ion channel disease. Remember, hypertrophic cardiomyopathy may not become obvious until 25-30. So if you test someone at the age of 16 and it's normal, it doesn't mean nothing will ever happen to them. And the Italian study, just for the sake of speed, they did serial screenings. They found that it took up to 3 serial screens to actually pick up lots of conditions, and these conditions got picked up after, not always got picked up on the first screen, several screens. So the last part of my talk is just to talk about some of you guys that go running and say, look, I enjoy myself. He's talking about all these deaths in elite athletes, but what about all of us? So here are death rates in the community. The red bars are your competitive athletes, the blue bars are your recreational athletes, and you see that the competitive athletes only make up 6% of all the sudden deaths I've been talking about. Most deaths occur in the community, and they're generally in men aged between 45 and 55 years old, and then due to coronary artery disease. The question is, how do we pick these guys up? Guy goes for a run, doesn't come home again. How could this have been picked up? Now, obviously, we can't do CT coronary angiography in every single male that wants to run. So we rely on certain things, and this is what we rely on. We rely on that individual's habitual activity. Someone said to me, look, I used to run marathons. I ran them until about 3 years ago. Then my knee started hurting. Now I want to start running again. I still go to the gym a lot, and I want to work to a 10K. You think, okay, that person's still quite fit. And, then we use something called the risk score. We use the score chart, which relies on age, total cholesterol, blood pressure, and smoking status. We've got a score chart of more than 5%. We consider you as high or very high risk, and we rely on other high established risk factors. And for the sake of the time, I won't talk to you about them, but these are all the high risk factors. For all these high risk factors, you need to be tested. So if you've got any of these, and you've got a low cardiovascular disease, as far as we've done on those tests, we would let you do everything according to the ESC. Okay? Now, if you've got high or very high cardiovascular risk score, we ask you, how much do you want to do? And if you say, I just want to go to the gym slowly, I don't want to do anything, we don't do any more tests. But if you say, I want to start running 5Ks, 10Ks, I want to do HIIT, in that situation, we want other data. We want a functional imaging test or a CT coronary angiography. And if this functional test is normal or good, if it's abnormal, showing high-risk features, we would want that individual to be revascularized. Clearly, I'll be the first to say this, and Mark and I used to have this little debate. I used to go on and on about screening, and he said, what about bedside care? You guys miss things. And he's absolutely right, we do miss things. We would miss about 30% of people that are exercising with the tests that I've just talked to you about. And we'd miss a lot of people middle-aged people. So what do? You teach the community to start thinking about bystander CPR. If someone just witnesses a cardiac arrest, witnesses it and calls someone, you increase survival by about 2.5-fold. If that individual starts CPR, you increase survival by about 4-fold. If an AED is applied quickly, you increase survival by almost 6-fold. Let's go back to the Lockyer incident. So Tom Lockyer had a reveal device in situ. So he's gone down at that point, and you can see the doctors on, but we could see what was going on. So here's the top. This happens at 16:15. You will see that he's got 3 ventricular extrasystoles that degenerate into polymorphic VT and then into VF. But look at that, 16:18, he's had his shock, idioventricular rhythm, and he's back out of it. So they were on him so quickly, they'd got him VF within under 3 minutes. And I think that's That's the elite sport has got that luxury. But I think we should be aiming for all of that in our sports gyms, and we should be educating the community. So in conclusion, regular vigorous exercise is associated with a constellation of structural, functional and electrical changes within the heart. Large males get the biggest hearts, African males get the thickest hearts. Differentiating physiological adaptation from cardiomyopathy is possible using a methodical approach. ECG screening is effective but does miss certain diseases, so a normal ECG doesn't exclude disease. Identification of middle-aged individuals with coronary artery disease relies on a pragmatic approach which takes into account habitual activity, symptomatic status and risk factors, and prompt resuscitation hugely increases survival. In fact, survival in places like London Heathrow Airport, casinos and football pitches is now over 80% after cardiologist. Thank you very much.
Welcome back, everyone. I'm Dr. Twisha Parekh. I'm the Sports and Exercise Medicine Physician here at the hospital in the Department of Sports Medicine. Hope everybody's had a little break and we are ready to start the panel now. So we begin with the cardiac panel. I'd like to invite Dr. Sanjay Sharma. We've already introduced him, so we thoroughly enjoyed the lecture, and get ready, there are already a lot of questions pouring in for you. Next, I'd like to call upon Dr. Ajit Menon. He's a leading cardiologist, interventional cardiologist in the country for more than 32 years. He's a proctor for coronary intervention and intravascular imaging. He's a principal and leading investigator in multiple trials in interventional cardiology. He is also a committee member for various charitable trusts, and he is definitely a go-to cardiologist here in the city. So we welcome you, sir. Next, I'd like to invite Dr. Amit Vora. Dr. Amit Vora is a cardiologist in the city with more than 27 years of experience. He has a special interest in cardiac electrophysiology and is one of the leading persons for the same. And pacemaker, radiofrequency ablations, that's his real specialty. And he's established a lot of this electrophysiology programs at various centers in India. He speaks at a lot of symposiums, is a member of multiple societies, heads multiple societies within India, and has been a guest speaker internationally on electrophysiology on multiple occasions. So lastly, I'd like to invite Dr. Aashish, Contractor, the head of Rehabilitation and Sports Medicine Department at Reliance Foundation. I think he really doesn't require any introduction for most people here in the crowd, but just for the sake of completion, everybody knows he's an avid runner, athlete, sports enthusiast. He's on the academic front. He's also the fellow of the American College of Sports Medicine. He is quite the go-to person for most of us here when it comes to sports and exercise. So I welcome everybody, and we'll begin the panel. So we've got a couple of questions from the audience. If there are any more questions, please hand them over to Mr. Prasad, who will just walk around and pick up the question cards from you. In the meanwhile, sir, the questions so far to everybody in the audience largely, but Dr. Sanjay Sharma, you mentioned about the tests that somebody should do, but I still have already got about 6 cards with me which are asking about what should be the test that somebody should consider, especially now we're talking, people are really going much more into ultra marathons, high altitude runs. I think the marathon, the 42 is no longer people are going much more for that. So anyone from 35 years on, and largely it's that population which is doing this. So you did briefly tell us about the hierarchy, the algorithm for the test that should be run, but could you again, for the sake of the crowd, make it a little bit more simplified for them?
Yes, of course. Firstly, as you said, these ultra marathons are really they're gaining increased popularity, and in some events, maybe the Mumbai Marathon, there are multiple thousand people entering these. So before I say anything more, clearly one has to be practical about how far we take things, because if we look at deaths, even if you look at the Mumbai Marathon deaths, they're not common. So the incidence of sudden death during a marathon is around 1 in 50,000. Okay, we've got to remember that before we get excited. Point number 2, if someone comes to see me and says, look, I'm entering an ultra marathon or a Mumbai marathon and I want to be checked out because I'm a bit worried, because when you spoke to us, you said if you've got symptoms, you should be checked out. So if you've got heaviness in your chest when you exercise, if you're disproportionately breathless when you're exercising, if you're feeling lightheaded when you exercise, if you're having palpitations, your heart's beating, or if you blacked out, those are bad signs. Symptoms. You need to get a cardiologist to say good or bad, or are they important? Secondly, if you've got high blood pressure, diabetes, a high cholesterol, or a family history of deaths from heart attacks or stroke, you should be checked out. Thirdly, if you've not done any exercise and suddenly someone says to you, look, why don't you raise money for some, child organization, and it's so close to your heart, you think, you know what, I'm going to go and run. So if you're not fit, if you've got symptoms, if you've got risk factors or family history, you should go and see a cardiologist. The cardiologist will do an ECG, they'll do a heart scan, because obviously in people in their 50s and 60s, there may be something wrong with the valve, a narrowed valve. They'll do an ECG to look for electrical faults. And someone like me will put you on a treadmill, and I will make you go as hard as you possibly can, because we want to exhaust you completely on the treadmill until you say, I just can't do anymore. If all those 3 tests are normal, and I don't think you are at risk because you haven't told me because your cholesterol's not high, your blood pressure's not high, I may drop it at that point. But if you've got risk factors, I personally would want to do something called a CT coronary angiogram to see if you've got a stenosis, which may not be shown up on the exercise test, for example, a 50% stenosis, or if you've got soft plaque. So in our arteries, we've got furring up, and that furring up can either be chalky, stable, or cheesy, unstable. So if you've got lots of cheesy plaque in your coronary arteries, I would be a little bit more concerned. So apart from advising you about the marathon, I'd also be talking to you about a statin to try and harden those plaques. So I would do those tests on you. Does that make sense? If, of course, I find a 50% narrowing, then I'd want to see if it's significant or not. An exercise test is not as good as functional imaging. I may then want a stress echocardiogram, a myoperfusion scan, or a stress MRI perfusion scan to make sure there's no lack of oxygen. But that's how I would take it. But I do try very hard to be as pragmatic as possible. We've got 52,000 people running the London Marathon in 4 weeks. Can you imagine if all of them wanted cardiac investigations? We would not cope. So we give this advice. This advice that I've given you goes out to our runners 3 times when they enter the ballot to remind them that there are certain people that should seek medical attention.
Yeah, great. So in continuity to that question, so CT angio, because this is something that we get asked frequently, that if there is only a family history, if there's a family history of early cardiac death, the person doesn't have any complaints, no other risk factors, but just this thing, should the person then undergo a CT angio?
If there's a family history of premature atherosclerotic coronary artery disease, i.e. a death from a heart attack, definitely I would want that checked out. Because, as I said, an exercise stress test will not pick up a narrowing until it's 70% or more. So we won't see it. And the other thing is, athletes, they have very good endothelium. That's the lining of the arteries. And the endothelium produces a chemical called nitric oxide. So when these guys even think about exercising, their arteries distend straight away. So you're less likely to see a stenosis in an athlete. And that's why if someone's giving me a history like that, even if they're asymptomatic and they've got a negative exercise test, I'd want to do a CT coronary angiogram.
Dr. Menon, anything on the Indian perspective on this, especially looking at the Indian ethnicity, anything that you'd like to add on this particular front from the CT angio point of view or testing point of view?
From the Indian perspective, what we do see in Indians is that we have a very high load of diabetics. So our disease patterns are different from the Western population. We don't have the big arteries that the Westerners have. Most of our arteries are pretty small. They are the extent of what we call as diffuse. When we say diffuse disease, it means cholesterol deposits along the entire segment of the vessel. That's much more higher in the Indian population than in the Western counterparts. We need to remember one thing, that in our subset of patients, being lean is not necessarily healthy, because you have something called as visceral fat, which needs to be assessed. And Indians have something called as the thin fat Indian syndrome, where you have a thin Indian, you have a thin European. The visceral fat or in the European is about 7%, the Indian is about 21%. So that also adds to our risk profile in our patients. Talking about the investigations that we ask for, very often I am asked in a clinical mode, is a 2D echo good enough? I have done an ECG and a 2D echo, my heart is fit. An ECG tells you just the situation at that point of time. It does not tell you, it does not have a predictive value of what can happen in the future. It just tells you what the ECG is at that point of time. You can do an ECG, walk out of the clinic and have a heart attack outside the clinic. So the ECG is not something which is, it's good if the ECG is normal, but it doesn't predict what can happen. 2D echo, it tells you again the heart pumping at that point of time. It doesn't tell you anything beyond that. So what was said in terms of, what Dr. Sharma said in terms of exercise testing, and in certain patients, the CT angiogram, because I think, in certain high-risk situations, diabetic, very strong family history, a family history of sudden cardiac death, these are the patients where we would probably go for a CT angiogram. But again, I would go stepwise, probably a routine, a stress test or a stress perfusion imaging to begin with. And if that shows anything, then go ahead and do a CT angiogram. Again, if you are an athlete going in for very ultra high marathons, possibly yes, a CT angiogram would be a good idea, because it picks up plaques and it picks up a very high risk morphology plaques with a lot of cholesterol deposits in the plaque, which are prone to give trouble when you exert too much.
Thank you, sir. Dr. Amit Vora, when somebody has ECG done and they have an abnormality conduction problem, they get referred to you. That would be fairly straightforward in a way. But can you describe some other causes or other symptoms for which somebody should approach you before they've even had an ECG? So are there any symptoms? What are the basic reasons that somebody should approach an electrophysiologist specifically? Electric specialist specifically, cardiologist.
I think the common symptoms which we get referred to and we should be be asked to look into is in terms of fainting or dizzy spells, blackouts and palpitations. So giddiness, pre-syncope, syncope as we call it. So if that is the case, and if you have palpitations either at rest or in exertion, unduly rapid palpitations. So, it's important to realize that palpitation is something which all of us would have, but if it's an abrupt onset, all of a sudden, and it's very rapid, and if you're able to take your pulse and it's 150, 160, to at least twice the baseline or twice the normal, then this is something which is not normal, not physiological, and needs to be further investigated. And I think giddiness and blackout is one of the important things, either exertional or even non-exertional giddiness, blackout. The commonest cause of fainting is, as we call it, vasovagal or neurocardiogenic syncope, which is, a little bit of dehydration, heat, sweat, and you have a common faint. But it also is important in what kind of company it keeps. So if you have a person with known cardiac risk factors or structural heart disease and has had these fainting or dizzy spells, then it's very important to have a proper detailed evaluation done. And of course, shortness of breath and fatigability are the other common symptoms which people with heart rhythm disturbance have. So if there is significant bradycardia, it may lead to shortness of breath and easy fatigability, and then it's worth evaluating them.
Thank you. That was really useful, sir. This was all the prevention. Dr. Contractor, what I'd like to ask you is, every time some marathon happens, we've been, not just marathon, we've been hearing of people, fit people collapsing in spite of, just like Dr. Menon said, just being thin doesn't equate to being fit. We are unfortunately seeing that being fit and being able to do a marathon is not equivalent to immunity to collapsing and losing life. So what would you like to say on that?
So as Dr. Sharma said in his talk, that anytime a young person has a cardiac event, it makes disproportionate headline and news, like it should, because it's obviously shocking, especially if it happens during a run. And people always then come and ask me or ask others that, oh, so-and-so was so fit, how could it happen? Now, as he elucidated, there are different risk factors for having a heart attack, starting from your family history, diabetes, smoking, high blood pressure, high cholesterol. So just because someone is fit, that doesn't mean he or she doesn't have the risk factor. So when someone who's fit has had a heart attack, and I don't mean to say this in a light-hearted way, it's like saying the car had perfect brakes, but how did it have an accident? Having perfect brakes is one aspect of preventing an accident, but just because the car has got perfect brakes doesn't mean you cannot have an accident. Similarly, fitness confers protection against heart disease. It doesn't give you immunity against heart disease. Just because you're fit doesn't mean you cannot have heart disease, right? It does reduce your risk. So your whole risk factor profile needs to be addressed. Having said all of that, there will be some amount of cases, even in the young, when they said they did the autopsy, in a large number, they found nothing wrong. So beyond a certain point, there is the human, if you want to call it the unknown, which you don't necessarily have all the answers. The other common misconception is we call everything a heart attack. The newspaper typically reports everything as a heart attack. So when a 20-year-old football player collapses on the field, it's not a heart attack. It's usually due to other conditions like hypertrophic cardiomyopathy, which is leading to a cardiac arrest. So usually over 30-35 is more commonly seen in the heart attack category in this sort of preventable, while the under 35s are more, other conditions.
Thank you, sir. Taking on from that question in the young that you mentioned, Dr. Sanjay Sharma, you are part of this CRY, the cardiac risk in young. So we have, I think pretty much the whole of audience sitting here has young kids who are playing competitive sport. So would you advise, they're playing competitive sport, they may not be, yet at the elite sport level that they are getting assessed and regularly evaluated on a regular basis. But would you still, what would be your advice for these kids who are playing competitive sport, which is fairly vigorous? At times, from the training histories that we get to know, they are doing decent amount of 4-5 hours of sport a day, varying intensities, but at times when they are into, like I said, competitive sport. So should they undergo any testing, evaluation on the cardiology front?
That's an excellent question. And, there's one thing me standing up here and preaching screening, and bearing in mind, remember, that when we do this, even in the UK, the service that I was talking to you about is confined to elite athletes. Our grassroots athletes don't have that luxury. So when I'm speaking to the world globally, by saying everyone must have something done, you put a lot of pressure on a health service. What I want to impress upon parents that are listening is that sudden death in the young is not common. It's very important that you know that. So if we're going to be practical, the sort of people that must be screened are those that are actually exhibiting cardiac symptoms. So if you've got a young boy that's expressing chest pain when he or he's exercising, or a girl that keeps blacking out, or is complaining of palpitation, or if someone's father died at the age of 40 and you've got a 15-year-old who's a really good football player, those sort of people definitely should be tested. Now, whether we test others, of course I would, I'm pro-screening. I'll just give you some stats. So in the UK, we don't promote screening for healthy people. If you went to see your GP, no one would screen and say, I've got nothing wrong with me, can you check me out? They'll throw you out. They'll say, we've got more important things to do. So In the UK, we did a study and we tested 140,000 young people aged 14 to 35, and we followed them up for 6 years. We found a serious cardiac condition in 1 in 300, like I told you today. In those that we found a serious cardiac condition, 40% ended up having life-saving therapies such as ablations, pacemakers, defibrillators, and even surgery. I should also then tell you that despite screening, 1 in 1,250 people died despite us clearing them. Okay, 1 in 1,250 people ended up being diagnosed with a condition 6 years later or dying, and 1 in 333,000 people died. So it's good, but we will miss a very small number of people as well. So I'm giving you the goods and the bads. I hope that allows you to make your own decision whether your kids should be screened or not.
Again, in continuity with this, so we saw a little bit of rise of this post-COVID. At least that was the way it was projected. So anything, so Dr. Menon, Dr. Sharma, Dr. Menon, have you noticed any rise of this? Dr. Sharma, in your studies, have you all done research to show that COVID had anything to do with this?
What we have seen, we do see a marginal increase in the number of youngsters coming with heart attacks or coronary episodes over the last 2-3 years. Do we have something to say that it is directly linked to COVID? Probably no. We don't have any definitive data that says that it's linked to it. During COVID, we had a lot of patients who came in with heart attacks, who had a lot of, basically, when you have heart attacks, you have 2 or 3 situations. One is you have a pure clot, a pure thrombus. That's a pure clot inside the heart. And that normally, by aspirating it or giving some medications, can dissolve. You don't require a stent or you don't require anything inside the vessel. The second situation is you have a patient has a block, the lining ruptures, it forms a clot, and then the clot leaves a blockage behind, which needs to be treated. What we saw in COVID in quite a few cases was an increased incidence of pure clot formation, youngsters coming with that, and basically they had a lot of what we call as thrombotic episodes. Now, does that explain the extension onto the situation now? We are not very sure. But what we do know is that COVID was an inflammatory disease. It caused a lot of vascular inflammation. It caused a lot of issues in the thrombogenicity. As a part of that process, probably it has incited certain vascular or endothelial dysfunctions in the vessels, which are probably progressive. I don't think anyone knows about what the after effects of COVID are, and probably we won't even know for the next few years till research tells us where exactly do we stand with respect to the pandemic. But labeling it as because of COVID, I'm not sure. But yes, we are seeing a higher incidence of youngsters coming in with coronary artery disease.
Dr. Sharma, do you have to add anything from your experience in the UK?
I can only go and we've got something called the CRI Centre of Cardiac Pathology, where anyone young that dies suddenly, in the UK, a post-mortem is mandatory in someone like that. It's by law to exclude foul play or suicide or deliberate self-harm. So if the pathologist doesn't find anything obvious, the heart is sent to us. We check the heart and it's repatriated back to the body afterwards. We did not find, so obviously we were in COVID, whereas we're hearing that you can get increased thrombogenicity. The other thing that can happen with COVID is inflammation of the heart muscle, causing myocarditis, which may cause a sudden death. And you may have read on Twitter and other social media that you were hearing that more sportsmen were dying. Whether this was true or not, I don't know, whether it was just more reporting. We didn't notice that in the UK, and we certainly didn't notice in our general population a higher prevalence of myocarditis over the 2 years of the pandemic compared to previously. But as I said, this vaccine thing that everyone's worried about, it's a long haul game. The data from certainly Israel and the United States suggest that your risk of getting a COVID-related myocarditis vaccine is 200 times lower than your risk of getting myocarditis due to COVID itself. But we'll see.
When we're talking about COVID, there was a big thing about how do we return back to running for those people. And not just COVID. Now, I mean, COVID is probably over, but we are seeing a lot of viral illnesses. So, Dr. Contractor, I think, because we especially have this cardiac rehab program running where people come regularly, and intercurrently these people do end up with some viral illnesses. Of course, we have a protocol that they should have a negative test, etc., so many days. But from the cardiac standpoint, this is a question from the audience. How does a heavy viral load of flu affect a runner's heart? What tests can be done before she can start exercising?
So again, sort of similar to the COVID examples that were given earlier. First of all, if you're unwell, you have the flu, you have a virus going, you shouldn't exercise. That's very clear. And that message is important to people in the audience, because I know lots of people sitting in the audience here who would be running even if they have a slight illness or a flu. Okay, so that's rule number one. If you're unwell, you have a fever for any cause, not necessarily virus, you shouldn't be running. You need a rest period. Now, how long do you wait after you're sort of symptom free or illness free is a hard one to answer, and it needs to be individualized. I was speaking to someone earlier and they had a viral infection with chikungunya, for example. Now that causes a lot of muscle ache and pain which goes on for several months at a time. So a person with that may not be able to exercise for several months. Someone with a, if I may use the phrase, regular flu, once they're completely symptom free, I think they definitely can get back gradually to the regular exercise. Anytime you have a gap in your exercise, especially if it's due to illness, remember you need to take a few days to get back into your normal rhythm. So you don't just pretend like that 2-week illness didn't happen. You take a few days to get back into your normal self. The question which was floating around earlier, which I think Dr. Sharma was also referring to, is, after COVID, should everyone have, for example, a scan to rule out myocarditis and things like that? And that, I think, was overplayed. And I don't think that everyone necessarily needs to have cardiac screening done just because they've had a viral illness and once they're symptom free.
Thank you. In our cardiac rehab, obviously we have a lot of patients. So Dr. Amit Vora, what would be your experience with pacemakers, ICDs and strenuous exercise?
I think pacemakers and ICDs, these are now devices which are commonly used in cardiac patients, and pacemakers are mainly for slow pulse problem, and ICDs are defibrillators which are used for people who have ventricular tachycardia or fibrillation to prevent a cardiac arrest or abort a cardiac arrest. More and more such patients are coming. Now, pacemaker, bradycardia, slow heart related pacemakers, generally majority of the patients do have a very preserved cardiac function status, and therefore they should be encouraged and they should be allowed to do exercise. I mean, of course, all these exercises should be in a graded, supervised manner to begin with. They need to be properly evaluated in terms of the cardiac status, and in consultation with the cardiologist, be advised further to continue with their exercise regime. But in short, pacemaker patients are more likely to get back to a normal activity which they were used to doing before, and more or less similar to people with not having a pacemaker as well. As opposed to patients with defibrillator. Defibrillator is often used in patients who have sick hearts, and because of their hearts being sick and it being used to prevent a ventricular tachycardia or rapid heartbeats, and it delivers a shock, one needs to be more careful. With ICDs, a patient can be allowed to have normal activity and a very restricted activity, very supervised activity, but very, very unlikely that he is going to be able to do anything like a marathon or anything like a gymming activity or unsupervised physical activity. Because with exercise, the heartbeats can rise. With the high heartbeats, the device can detect it as a ventricular arrhythmia, can give an appropriate or an inappropriate shock. So I think a lot of restrictions might continue in patients who have an ICD, but not so much with pacemakers.
Thank you. So on that same note about when we're talking about these devices and these procedures, I remember I had got one of our young male hurdlers to you, about 20-year-old boy. He was part of our high performance program. We were grooming him, and he was accidentally as part of our evaluation we do basic ECGs, and we picked up Wolff-Parkinson-White syndrome. So I remember I got him to you, and you had suggested some interventions, but he and his family they refused it. They refused the intervention. So have you seen such situations? And for monetary, non-monetary, whatever reasons, if people refuse this, so they are then continuing sport. So he's continuing sport, but without the intervention. What would happen in such a situation? Do you see these situations often?
So, Wolff-Parkinson-White syndrome or pre-excitation is an abnormal ECG seen in young people, and they have a potential, there's a 1% chance that they will have a very rapid heartbeats, which can be fatal and can lead to a cardiac arrest also. Cardiac arrest may happen in only 0.1%, but at least palpitations and giddiness, fainting can happen frequently in these people. So if a person is detected to have pre-excitation, he may not have any symptoms. If he has symptoms, undeniably he has to undergo the procedure and get that fixed. But asymptomatic person on a routine screening has been found to have pre-excitation. Now he wants to pursue or is a part of a competitive sporting activity, then we definitely need to be able to sort out the problem, because with excessive competitive sporting activity, the sympathetic drive is very high, and when the sympathetic drive is very high, these people with pre-excitation WPW are known to get into tachycardia. And one of the unfortunate reasons of a cardiac arrest in young, less than 35 years of age in sports and athletes is because of Wolff-Parkinson-White syndrome. But what we tend to do in terms of asymptomatic pre-excitation or WPW is to try to evaluate them by not only a single ECG but doing a Holter's test or a stress test. A Holter or a stress test does help us to understand whether the abnormal ECG pattern is continuously there all the time or is intermittent. If it is intermittent, then they are a little in the safe zone, less likely to have malignant cardiac arrest kind of events. But if they have a persistent pre-excitation all the time, we at times subject them to a stress test on a treadmill. On a treadmill, we look at the pre-excitation pattern. If there is a sudden disappearance of the pre-excitation pattern to a normal pattern, again he is in a safe zone, and then we may probably want to continue not doing anything for them. But yes, for competitive sporting person, it's unpredictable, and they are often advised to get their pre-excitation fixed.
Thank you. We have a question from the audience. What are the chances of finishing a comrades with an ejection fraction of 30%? Dr. Sharma?
Finishing a what, sorry?
Comrades marathon, ultra marathon.
It would be a bad idea, if you were to ask me, really, unless you were thinking of walking it very slowly. Obviously, when I told you earlier that when you're exercising like this, you are increasing your cardiac output from 5 liters per minute to 25 liters per minute. If you just imagine your 5-cylinder car had only 2 cylinders and you were trying to push it at 100 miles an hour, I think it would break down quite quickly, right? So there is a chance that you could run into trouble if you were going to run this properly, for lots of reasons. From arrhythmias would be my biggest worry, and obviously collapse from cardiac fatigue. So if you were my patient and you had an ejection fraction of 30%, and you said to me that you wanted to run the Comrades Marathon and you were really passionate about raising money for something because you'd promised someone that you were going to raise something, I would support you by saying you probably should walk it, but I would not encourage you to run it.
Dr. Aashish, we have a lot of questions about from the audience about zone. I think 7:15. I'll take this maybe as the last or second last question about running in zone 2, 3, 4 with. So, when somebody has a cardiac condition, how should they be running? What zones?
So basically zones are dependent on relation to your maximum heart rate. So normally the best way to know your maximum heart rate is actually to do a stress test and push you to maximum. Now most places don't push a person to maximum, and they go by a predicted formula, which is 220 minus your age is your max predicted heart rate, and various percentages of that max heart rate are your various zones. So zone 1 is absolutely easy, sort of almost doing nothing. Zone 2 is very moderate, and so on and so forth. And zone 5 typically is the highest. So it just comes back to most of the thinking on the subject is that 80% of all your endurance activity should be largely in the lower zone. So it should be at a comfortable pace, conversational pace. You should, while you're running, for example, you should be able to talk to someone next to you. And maybe about 20% of your overall weekly volume could be at the higher intensity, where you're pushing yourself, doing a few intervals. That would probably be the best way to do it. Now, in individual cases, and I know where a lot of these questions are coming from, also we need to evaluate them on an individual basis. It's very difficult to give a generic answer when you give only one statistic of information, because all of these other pieces also will go into making a sort of a rational decision. And at the end of it, it's a matter of risk perception, because apart from, it's very rare for a doctor to be able to tell you 100% that something will not happen. That they certainly can't. Nor can they often tell you 100% it cannot happen. So like Dr. Sharma said also, it's a matter of when the football player comes and you allow him or her to play, you're allowing their life to go on, but you're taking that risk. So I think as doctors, our job is to often delineate the risk profile and give all the facts in front of you. And then beyond the point, you're an adult and you can take a call based on all the information. I think that's important. The shared decision making, I think, is also important.
Yeah, and I think so. I think what I should have said also, that you need to, obviously we wouldn't just give you that advice. We'd have to make sure that you're optimally medicated, that you're on the 4 pillars of treatment, beta blockers, either Entresto or equivalent, an aldosterone antagonist, a dapagliflozin, so you're well treated. I would obviously want to do an exercise test, anyway, a max exercise test to check your VO2 and to check for exercise-induced arrhythmias. Those 2 things would certainly influence whether I tell you to jog a bit and walk. But still, I always tell people who want to run a marathon that no matter what I say, our laboratory tests cannot simulate what goes on in a marathon. So we shouldn't be overly reassured by laboratory tests.
I'd like to pose the last question to Dr. Ajit Menon, and that's going to be on females. So again, when it comes to running, in general with physical activity, we are seeing more and more females in their older, not older, but in their post-40s and especially post-menopausal women who are taking up exercise and who have maybe started exercising before, and I especially as a sports physician get these complaints that they say that they're finding it quite different in the post-menopausal phase. So is there anything to do with cardiology around that? I know Dr. Sharma, you've spoken, I've seen one of your talks wherein you're talking a lot about females versus males. In general, we know females are at less risk of cardiac conditions, but anything else that females should be careful about, concerned about, because they do feel some changes in the postmenopausal state?
I think in terms of cardiac evaluation, post-menopausal, I think once you reach menopause or in the perimenopausal or the post-menopausal stage, your risk is as good or worse than a male of the same age and with the same risk factors. I think for people who start exercising at a later age, I think the same advice would go to either to men or women. If you are starting to exercise at a later age, get investigated before you do anything. Get your routine checkups done. Even if you feel that you're healthy, you have no symptoms, what Dr. Sharma and Dr. Aashish said, in terms of the level of exercise that you do in marathons or running, that you can never replicate even on a routine stress test. A stress test is only for 7 minutes, 9 minutes. And the moment you reach a specific heart rate, you stop the test. You don't go beyond that. Marathon running is a different thing altogether. And I think if you have people who've been running all their lives, that's a different thing. But in people who start at a later age, get evaluated get a routine evaluations done. And I'm not sure whether there's a difference amongst premenopausal and postmenopausal women in terms of marathon running.
Well, we've got a paper that's going to be coming out, but that may not necessarily answer all your questions. But you may have heard, some of you, that men that have exercised all their lives and run marathons all their lives, 1 in 5 men show either a coronary artery calcium score of more than 100 or a stenosis, okay? So one thing we know, and I can promise you this, that running does not protect you from atherosclerosis. We know that. And if you look at the coronary artery calcium scores in runners versus those people that don't run, they're the same. Okay, so that's the one. But we have not been able to link that calcium in marathon runners with mortality, with deaths. And we feel that the mechanism of this calcium may be different to the mechanism in smokers and hypercholesterolemia. Now, if we look at female counterparts, so we took 200 odd females who had exercised for 34 years. These are women in their late 50s, and we compared them with controls. Unlike men, the women didn't show high coronary artery calcium scores. They didn't show plaques. Indeed, they showed a slightly less coronary artery calcium score compared to sedentary women. So women, just like AF, seem to behave slightly differently. Whereas with AF, there's a U-shaped curve that you protect yourself from AF until you do very vigorous exercise. Then some men get more AF. But with women, it seems that they seem to have this inverse relationship with intensity and arrhythmia, and they seem to be showing the same pattern. But having said that, these women had only been menopausal for 4 or 5 years. So when we found atherosclerosis, it was confined to women aged 65 or more. So someone said to us, why didn't you have more than 65-year-old women in your club? But once you start testing women who are 65 and 70, then age is such a confounder that you can't be sure whether it's age or something else that's doing it. But it was good news for women generally.
I think that we've come to the end of time to close this panel. I think I thoroughly enjoyed it and found it super informative. I think I can speak on behalf of the audience for this. I'd like to felicitate, I'll call upon Rishika from marketing to felicitate our panelists over here. Dr. Amit Vora. Thank you, sir. Dr. Ajit Menon. Thank you, sir. Dr. Sanjay Sharma. Dr. Aashish, Contractor.
Thank you, Dr. Sharma, Dr. Menon, Dr. Vora, thank you very much. So the last panel is looking at training and a sports medicine load. Again, we've got a loaded panel, pardon the pun. Dr. Mark Gillet up on stage first, please. He's already been introduced. Next, we've got James Hillier. James, please come on stage. He's the Director of Athletics at the Reliance Foundation. He is formerly the head coach for speed at England Athletics. He's worked as a high-performance coach at British Athletics, covering 2 Olympic cycles, 2012 and 16, and he's coached numerous international medalists. Most recently, he's helped our own Jyoti Yaraji break the Indian national records 11 times in I think about a year and a half. It's absolutely a fantastic story. So, and James is hopefully going to help India win many more medals. Next, we've got Ben Langley. Ben, would you come up, please? Ben's a physiotherapist. He's originally from Australia. but he's worked as a lead physiotherapist at the Worcestershire County Cricket Club from 2008, and then he joined the ECB, and for the next 12 years had the role of England men's physiotherapist, national lead physiotherapist for men, women and disability. And most importantly for us, he's joined the Mumbai Indians, and now he's the global head of sports science and medicine for the IPL, WPL and all MI franchises. Ben, good luck for the game today, big game. And then we've got Shiva Keshwan. Shiva is a 6-time Olympian. 6-time. So he went for his first Olympics at the age of 16, and he was the first Indian to represent India at the Winter Olympics. And he's done 6 Olympic cycles from the age of 16 to 36, and he's in the sport of luge, where he holds the record of hurtling down an icy slope at 149.9 kilometers per hour. So welcome, Shiva. And last but not the least, we've got my colleague Chris Pedra. Chris is from South Africa originally, and Chris heads our sports medicine division and works with both our elite athletes and our elite amateur athletes, many of whom are in the audience as well. So thank you very much. So let's sort of jump into it right away. We're going to talk about load and what is optimal load and when's it too much. It's the same way we spoke about load kind of from a cardiac angle. Now we're looking at it from a physical angle. And to get the ball rolling, Chris, what do we mean by load, and how do you define it from sort of a general fitness point of view?
Thanks, Aashish. So it's effectively the stress that your body is kind of experiencing when you are exercising. That's the sort of basic crux of it. So there are a number of different ways to measure it, and it's become quite a hot topic probably in the last decade, maybe 15 years. The concept of load management, effective workload management, and a lot of people have used it to try and justify certain approaches towards training. They've tried to use it to predict injuries. They've tried to use it to prevent injuries, obviously. But the basic crux of it is trying to put a number or a figure or something objective on what your body is experiencing when you're exercising. So the most common, I suppose, metric that people talk about is acute chronic workload ratio, that most people probably have come across the term ACWR. In the last few years, it's been quite controversial. A lot of people arguing that it's actually not nearly as valuable as it was originally thought when it first came out. Everybody was clamoring to use ACWR for predicting everything. But now I think research has shown us that, as with a lot of the things that we measure, it's just one way to do things, and it doesn't necessarily ring true for every, or isn't super valuable for every single, situation when you're trying to measure. But I think the concept is what's important, more than trying to use it as an absolute value to predict anything. So the concept that your immediate load that you're going through while you're exercising now should be relative to what you chronically have been loading, if that makes sense. So whatever you're doing now should be in some way related to what you're prepared to do, which would have been what you have been doing until now. So acute load technically in this ACWR concept would have been the past week of load. So let's say Monday to Sunday running for most of our audience members, I think. And then that would be versus the average load over the previous 4 weeks. So if you were running 30 Ks this week and your average load for the last 4 weeks was 28 Ks, your acute chronic workload ratio would be just above 1.05, probably something like that, which would put you in a good place to be progressing, progressive overload, and that kind of would be typically be the way that most programs would be planned. There are a number of problems with it, unfortunately, but the concept is sound. It's that progressive overload and trying to do it sensibly. So I think that's probably the most familiar, load that most people are talking about when you hear load in the media and when you're speaking to people in athletic circles.
We need to look at acute as well as chronic. Ben, dealing with cricketers is obviously a different ball game compared to amateur athletes. How do you see workload management being effective in a cricket setting?
Thank you. It's not easy. Following up on what Chris has just said now, things like acute chronic workload ratio, where we're looking at someone's workloads from a day-to-day basis, isn't helpful in cricket, especially if we start talking about the biggest problem in cricket from an injury perspective is your lumbar stress fracture, which can keep players out for obviously very, very long periods. Some of the things that we found when I was working with the England and Wales Cricket Board, what was more important was your total career overs. So someone was at much higher risk when they were under 1,300 career overs. So until you'd reached that point, you probably hadn't had enough exposure to high-level bowling, which would encourage obviously the bony adaptation that you need to provide some prevention against you suffering a stress fracture. We, especially post-COVID, that couple of years where cricket was really restricted, we saw a lot of young bowlers who didn't develop the catalogue or background of workload that we wanted to see. So I can give you some examples. We had a player who was probably far less fit, and if you looked at him, you thought, this person doesn't look ready to play Test cricket. But he had bowled. It was a metric that we used quite regularly. Someone that hadn't bowled 20 overs in an innings, which we'll say 20 overs in a day. This player had done it over 50 times, and despite the fact that he wasn't necessarily the most physical specimen, he'd obviously had that bony hardening that you needed by having bowled that number of times. We had two other players who looked far better physical specimens, far more athletic looking. They had bowled 20 plus overs in an innings only half a dozen and a dozen times each. They were the ones that broke down with stress fracture and then ended up missing a long period of time. Now, fortunately, we had waved the flag to say to the selectors, look, these players look undercooked. They haven't done enough. And it's far more on that macroscopic scale than on the microscopic scale. Do they look ready to take on that big step up? And if they haven't bowled 20 plus overs in an innings at domestic level, where there's obviously no scrutiny and you just haven't got it's not the intensity of cricket that you do that you step up to if you're going to play international Test cricket, how are they expected to survive, really? So, sadly for those guys, we learnt the hard way. But I think going forwards, we're far more looking at trying to get that workload into the players on a bigger scale. So it's more match workload than necessarily the acute chronic workload of day-to-day stuff. So
thank you. So James, actually when I visited your center about 2 weeks back, I was sort of surprised to find that the sprinters actually got on the track about 3 times a week or 4 times a week, and I thought they would be on the track morning, evening, sort of every day. So how does one look at load and workload in an elite sort of athletic sport environment?
Yeah, athletics is a interesting and unique sport, particularly when we look at sprinters, because intensity is always the biggest factor that we must consider, and athletes create their own intensity. So, sort of counterintuitively, the better the athlete, the less the athlete can do. So if I've got my 3-year-old son, he can run to the end of there and then he can run back with about 2 seconds recovery and he can run back. If I have Usain Bolt here and he runs down to the end of the room, he's going to have a lie down for 10 minutes afterwards because he's expressed so much force and so much intensity that he needs to recover from that. So we must always consider intensity. So it's sort of counterintuitive. The better the athlete, the less they can do. And the other thing is we can only train athletes, and this might be relevant actually for everybody in the room, but you can only train athletes to do what they can recover from. And it's really important to remember that. If you give an athlete too much and they can't recover from it, you're going to break down somewhere. Something's going to happen. You're going to get sick, you're going to get injured, and whatever else. So, we have to, in elite sport, we have to consider the not only the athlete that's in front of us, the individual that's in front of us, but we have to prepare that individual to do the event, the competition. So there's constants and variables. So if we're looking at, let's say, the Olympic Games is coming up in 2024, let's say we want to try and win a medal in the, let's say our own Jyoti Araji, our top Indian hurdler that I coach. Let's say we want to get her in the final of the Olympics. So we know that she's got to do 3 rounds in 3 days. That's the timetable. She's got to run within 1% and 2% of her best time throughout the competition. And we know that to win a medal at the Olympic Games, and we know this by the data and the stats, that you have to run faster in the final than the semi-final. 60% of athletes peak in the semi-final and they can't reproduce that in the final. So once we know what we need to do, then we sort of reverse engineer everything. So we kind of work everything back and then we look, okay, what are the constants of the event? We know the timetable, we know the intensity, we know what we need to do. Then we try and work, or we load our athletes to be able to manage the competition. We're not interested in anything else. Jyoti doesn't need to run more than 100 meters. So yes, we might do longer runs in training, but ultimately all she has to do is 3 races in 3 days over 100 meters and 10 hurdles. That's all she has to do. So endurance for her might be no longer than 200 meters, 250 meters, something like that. Endurance for her is not going for a 10K run like some of the ladies and gentlemen in the room here. So it has to be very, very specific. We have a young thrower that's training with us in Norway, extremely talented young boy. Young boy. He's only been with us for about 6-7 months. He came 4th at the recent Asian Indoor Championships. His best throw, unfortunately, was his last warm-up throw, which would have got him a medal. When it came to the competition, he'd sort of exhausted his energy and his sort of mindset had gone a little bit as well, and he didn't get a medal. Now, he's an athlete that we know he has the potential, but he hasn't got the capacity to do the work that is required to deliver a medal-winning performance yet, because we can't train him hard enough that he can recover from the work we give him. So, as Aashish said, we maybe train 3 times a week at our event-specific stuff. He can maybe only do it once a week at the moment. So when we can get him to go hard 3 times a week, then we hope he'll be in a position to go and deliver a medal. At the moment, it's more like hard, medium, easy. And I guess it's probably relevant for a lot of you in the room. Yeah, you can't push hard all the time. You have to build up to that. You have to build up to that. So I think going off a little bit off piste here from the high performance, but I think advice to you guys would be very much look at what the requirements of the event you're preparing for is, reverse engineer it, and then try and build yourself up so then you have the capacity to be able to manage what you need to do in the event.
Thanks, James. Mark, football is sort of a unique sport where not only do you require a large amount of skill, there's of course a fair amount of speed and endurance required. So what would your sort of advice for load management or training be in a football setting?
So I agree with James. So I agree with James. It depends what you're measuring and what population you're measuring. So I'll give you 3 examples. At Chelsea, if you're playing in the Champions League and you're in the team for all those games, it's all about recovery. There isn't enough time to train during the season, so it's purely about recovering from the workload imposed competitively on you. So that makes it to a degree very easy. You just have to make sure the players who aren't playing, that you manage their workload appropriately. When I was at West Brom, generally on most metrics, you're looking at a cumulative training week of between 1 and 1.3 times a match metric. So certainly the total distance, load scoring, which is a directionless assessment of multi-directional movement you'll get on a catapult system. Again, you're looking for a 1.2 metric. The only thing I'd say in terms of sprinting and high intensity distance, you have to be very, very careful, and it's very difficult to prescribe a generic ratio for those players. Again, depends on the age and position, what they're doing, what their max speed is, but you need to be very, very precise the way you do that. And thirdly, in terms of the sort of recreational athlete, particularly the middle-aged runners who are new to running, It's all about educating them about how to train properly. So rather than cumulative load, as Aashish says, it's about getting a high quality heart rate monitor, which is run on from a chest lead rather than a wrist lead. So that's really, really important. Agree with him completely that knowing what your maximum heart rate is very, very important. But also having a high quality heart rate monitor is very important so that you can look at it accurately. And knowing how you get that variability of training stimulus rather than just running long and slow every day, which is what most people tend to do. So that basic level of education I think is very, very important.
Thank you. Shiva, you've competed at literally the highest level for 20 plus consecutive years. How did your training change as you went from sort of 16 to 36, and what is that experience like?
Well, first of all, I'm very nervous sitting over here because I'm not a doctor, obviously, and every time I went to see a doctor as an athlete, they would say, "What are you doing? This is not the kind of activity that is prescribed." So before I give any advice, that's the rider on it. Of course, the sport that I competed in is what you'd call an extreme sport. Right? So we go at speeds of up to 150 kilometers an hour. We experience G-force, centrifugal force of up to 10 times, the force of gravity. So it's a lot of atypical situations that you subject your body to, right? However, in order to reach the stage to be able to perform under these conditions and repeatedly at that, there's a lot of preparation that goes into this. And one of the things that it makes it easy to explain is that as a seasonal sport, it's a winter sport. So the competitive phase of the year is stacked, during the winter months. So you have a whole, year of time to prepare for, how you want to be turned out, during the competitions. So of course, initially in India, first of all, the winter sports is not so advanced, and I grew up at a time where we didn't have much sports science. In sports, a lot of these things were intuitive. And generally, the rule of thumb would be listen to your body, and you know how far you can push yourself. However, the more we're getting into this, what we used to do is start off with the basics, with building your capacity, your lung capacity, your resistance. This was the first few months of the year was mainly resistance training, we can call it that. The next phase would be to prep our body for the actual luge event. Now, the event is very interesting because the number one thing is gravity that we are relying on, right, to get from the top of the hill to the bottom. It's just the initial 2-3 seconds in which there is physical explosive exertion when you can, launch yourself down. So you have to prepare for that. So you have to prepare for those 2-3 seconds in which you are, having that intense explosive movements. And after that, it's gravity. So gravity means weight, right? So we want to be at a high enough weight while keeping, obviously the important functionalities of your body in place, because you need to be agile, you need the balance and things like that. So after our resistance training, we would, have a few months in which intense strength and conditioning, right? You're eating, you're doing certain kinds of activities in the gym to increase your body weight, your mass. Then came the third phase, which was the explosive part of the training. Now you've built up your base, you've built up your weight, and now how fast can you expend your energy? So that is a different kind of training altogether. So the whole year was really periodized in this way, and of course, once we actually got onto the ice part of the training, the technical training, you're trying to basically maintain your physical characteristics, throughout the end of the season, and making sure that you're not burning yourself out in this, extremely strenuous activity. So for us, one heat, one run would be about 40 to 50 seconds, okay? And we could only do a maximum of 3 runs a session, and even if there's 2 sessions a day, it's six runs a day. So, it's less than 6 minutes of time that you're actually on the course. But beyond that, you cannot, because it gets counterproductive. And then there are so many nuances involved in this. One of the, without taking everybody's time, I'll just go ahead and give you one of the common misconceptions. Many people think that it's an extreme sport, it must be adrenaline sport, so people are really aggressive. But it's strange because the first 2 seconds, yes, you have to be aggressive, you have to be explosive, but then immediately you have to shift to a very meditative, relaxed state where your body can actually absorb a lot of the vibrations going down the track. If you remain stiff, it's like you let a piece of wood slide down a slope. It's stiff. The moment you touch it, it's going to spin in all kinds of uncontrolled motions. But if it's a piece of rubber, even if you hit it, it just kind of wobbles back and continues on its course. So it's interesting how you have to change your mentality, your approach, and also your physicality during this. And as James also mentioned, it's all about preparation. High performance sport is about a lot of times doing something that is beyond healthy, beyond just fitness. However, doing it, preparing for it so that you're safeguarding yourself and doing it in the most efficient way so you can get the most out of it for the result.
Thank you, Shiva. I can attest that you're not aggressive, you're very calm. I don't know whether you're stiff or rubbery, I can't comment on, but you're definitely not aggressive. Okay, so we spoke about load. Let's just speak quickly about two more things which people have an interest in, which is of course injury and then the new buzzword on the street, which is recovery. So Chris, very quickly, I think a lot of the people we would see at the hospital, clinic, etc., they're probably working harder than maybe even James's athletes in their endurance and 6 hours a day, etc. What are the two commonest reasons you see for injury? Just sort of a quick 2-point answer.
Yeah, I think it's actually a really good point. Is a lot of people unfortunately don't realize that. I sometimes say to patients, we're not actually performing the same activity. So people like to compare themselves to a Mo Farah or maybe I suppose Jyoti's a terrible example because there's not a lot of amateur hurdlers out there, but your distance runners are kind of the people that a lot of people in the room would be looking at and going, well, how are they doing things? What are they doing? But they don't have jobs where they sit at a desk for 10 hours a day and they sit in the traffic for 2 hours on their way there and on the way home, and they don't have life stresses like a lot of other people do, and their entire day doesn't surround their energy consumption, their diet, etc. So it really is a completely different thing. But then these people go out and they try and match the training intensities or the training volumes, etc. So that's probably one of the biggest mistakes that I see is people are just trying to push themselves too hard. And I suppose that goes with the theme of what we're talking about on the load management front. Everyone has given a good example of how you build this big base and then you gradually try to hone that base towards whatever your target is. James mentioned looking at your target and working your way backwards, and that's where you start. Now, unfortunately, people don't tend to give themselves enough time to do that. They, at the last minute or on a whim decide they're going to do X. They don't necessarily know how to work backwards from that, or maybe they don't consult the right person for that, but invariably they just don't have enough time to actually do what they want to do. Let's say they've decided they want to run TMM in January 25, but they've only decided in October, and they've also decided they want to do it in under 4 hours, and they're actually not a runner. So they've got like a heap of unrealistic factors going on here, but they're still going to go for it, and they're still going to do their job 10 hours a day and sit in the car for a year. So there's just too many things stacking up against them. I think that's probably why a lot of people fall short with their injuries. And you see it in the type of injuries that we find as well, is that most of the injuries are these overuse type of injuries. It's not, you don't get very many acute calf strains or acute quad strains or acute, muscle injury tears, hamstring strains in the people we see in the clinic. Of course, they do happen occasionally, but the bulk of them are basically training load errors. So it's the chronic injuries to tendons, your shin splint type of things, and then on the serious end of the spectrum, the stress fractures. But I think that's kind of the I don't know if I've answered the question exactly as you asked, but effectively the training load error is really the biggest issue we see, and that's mirrored in all of the injuries that we see, that come through the door.
Thanks, Chris. So Ben, I think every Indian parent wants their kid to become a cricketer and join the IPL. You mentioned about low back stress fractures, low back injuries. What's the best way to avoid that?
I was thinking of, I'll try and stick to two main points. One would be around, again, this workload management discussion. The evidence that we have achieved through research at the ECB was you are far more likely to get a stress fracture. One of the most important things with the number of non-bowling, I won't call them rest days, but non-bowling days, because you can still train and do other things on a rest day or a recovery day. But you need to consider how many days a week you're bowling. And it's very different in England, where we're often protecting a particular player. So we might have a 15-year-old spinner that's the only spinner in the country that we think might be able to play for England. We surround them with so much protection because they are so valuable. I think what I've noticed when I've spent time in India now is you might have 15 spinners that are good enough, and there's a lot less control around workload. It's more about, right, who's going to fight it out to be number one. So I've seen very different approach, but what that comes with, I hear very regularly, is fast bowlers might be bowling 6 days a week. Now, one day off, I think the important thing to note, bone as a tissue needs time to recover. We think how sore we can be after exerting pretty hard from a muscular perspective. Bone needs longer again to fully recover, and it doesn't probably start barking at you and telling you it's sore until it's too late. So one thing that I would consider, and it's very, very difficult because of the performance pressure that comes from coaches, especially as you get higher and higher up the levels, is to try and create some time for your body to recover, particularly bone, and to allow for that not just recovery but adaptation to happen at the same time. So 3 days a week of non-bowling is probably unrealistic in a lot of certain circumstances, but the more time you can buy a player, the better. That doesn't mean necessarily that they're going to bowl less. So in the UK, working with our bowlers, I would be saying, look, let's not cap your overs on a day necessarily, and that's obviously dictated to by a lot of things. We're not just going to say you can bowl as many as you like, because that's related to their capabilities at the time. But I'm far less likely to say you can only bowl this many a day and create a ceiling above them. But what I will do is try and say we're going to try and get through as many overs in the week, but we might try and create another day off where you're not bowling to give your body that chance to recover and to do other things to help yourself. The other thing that I noticed in the UK was, and this is, I'm focusing more so on our developing elite fast bowlers, so we're probably talking about your late teens fast bowlers. They were terrible at eating breakfast, and they'd be coming out to train and bowl as hard as they can with very little energy on board. So from a fueling perspective, and it was diabolical really. So, keep trying to remind them that, look, your bone is a metabolically active tissue. It needs energy just like your muscles do. We've had to almost push and train our players to eat breakfast a lot of the time and fuel properly. So they're probably two of the things that I would be looking at in a younger bowler is don't be afraid of workload. To take a step up, you're going to have to create a base. You're going to have to make sure that the word spike in workload management. I think the easiest way to avoid a spike is to make sure that your training base, you mentioned about intensity as well as the volume, is right up there. It gives you the best protection I think you can possibly have, especially as a fast bowler in cricket. So it would be something around that, creating that workload but sensibly, and also having a nutritional focus to make sure that you're giving your bones the best chance to recover and adapt.
Thanks, Ben. So we'll have the last sort of round of questions. Actually, you spoke a lot about nutrition, and Mark, I noticed one of the comments you had made, and let me quote it accurately. Last year for the Telegraph newspaper, you had said that a Premier League player consists of their last 100 meals. So do you want to elaborate a little bit on that?
I think so nutrition is very, very important, and I think So Premier League players, they'll have 3 meals a day, so they'll have 2 meals at the training ground, and if they want, we'll prepare a meal for them to take home with them. So completely spoon-fed and an individualised dietary plan for them. So I think that's really important. And also, bearing in mind that the late great Nick Broad, he was he was a great sports scientist in the UK. He worked with me at Chelsea and then went on to work at Paris Saint-Germain before being killed in a car crash. He was very adamant that the last 100 meals is your building block, and that's how you ought to evaluate a player's fitness and their nutrition. I think in terms of everyday patients, simple dietary advice is, again, you need to be very individualised and practical about the way you discuss it. I have a patient who I see from a wellness regenerative capacity who tries to do all the right things. He intermittently fasts, so he only eats between 12 and 6 each day. And on the face of it, his diet looks relatively healthy. It's a fair amount of protein. But honestly, there's so much fibre in that diet. I don't know how he doesn't implode on a day-to-day basis. He's constantly bloated. His calorie intake is inadvertently high, even though from a macronutrient perspective, he appears to be doing the right thing. So I think moving people away from very fatty media popular diets is very important, and giving them a variety of techniques that you can stick to. So intermittent fasting is a really good thing to get into if you can manage it, because it's reproducible. You can do it a certain number of days a week and then live a normal life, and that's one of those habits that you can introduce into your life that produces meaningful change. So I do think you've got to understand what you're trying to do, and you've got to understand what your outcomes are, and you've got to be very individualised with it, because it can be very difficult to break down the habits and the culture that people will have a very fixed idea about.
Thanks. Thank you, Mark. Last maybe couple of questions. James, from a high performance environment point of view, and actually even for the amateur athletes, how have you seen the role of sports science and medicine evolve over your career, and what are the kind of things that your athletes are involved in today, which from a sports science point of view?
I think I've been involved in athletics all my life, and so when I was an athlete, certainly there wasn't much in the terms of sports science. It was just rock up at the track, train till you puke up, and then go home and probably eat something unhealthy, and then have a few beers, and then go again the next day. A lot's changed. We're a lot more sort of looking after nutrition. Ben's touched on it, and Marcos as well. I think it's, even we can talk about high performance, we can talk about amateur sport. Like, there's a lot of similarities, and it's about the basics and doing the basics well. And I think if you can just be well organized, be sensible, common sense is really important. Yes, we can sort of use sports science, but sports science shouldn't drive anything. It should just inform. And I think it's important to establish a difference between data driving something and data informing something. I can honestly say that I don't think we've ever been shocked with any data that we've got in terms of we didn't already know it. It might have just reinforced something we already know, or maybe it's just given us a bit more confidence that we're doing the right thing, or maybe the wrong thing. I think common sense is something that's hugely important, and we're getting a bit faddy now, and I think you touched on it a few times today. There's all these fads and fancy things, and we've sort of got these aura rings now we've got our athletes wearing, and it's kind of good from one perspective, because we know they're going to sleep later than they tell us. So they tell us they go to sleep at 10, but we know they go to sleep at 12. We had one athlete that got so stressed about the ring that she couldn't sleep, so we had to sort of remove the ring from her so she could get a normal sleep back. But it's quite good because you get some information and you put it in the back pocket, and when they start moaning that they're tired, you can say, well, hold on a minute, you went to sleep at 1 o'clock last night, and now you're complaining you're tired, so no sympathy for me. So I think you've got to be sensible, and I think we've had good examples where we sort of had some sports science interventions, and actually the biggest thing that we got from it is a change in behaviour, and I think that's often overlooked. So if you can use these things, use these technologies, and then that helps an athlete change behaviour, because everything must come from the athlete. If the athlete wants to do something, then they'll do it, right? If we tell them to do something, they might do it for 2 weeks and then it just goes back to type, right? So if you can use technology and you've got an analytical person, and some of you endurance guys might be quite analytical with the numbers and stuff like that, and if you can use some of these fads just to change behavior and just, I think then there's definitely benefit in it. But I think, don't forget the common sense. Don't forget to eat well, sleep well. There's no coincidence. I mean, if we had a sort of award ceremony for the best sleepers in our high performance center, the best athlete is also the gold medal winner in the sleeping department. I mean, she's either on the track doing her thing, or she's horizontal in a room fast asleep, and you can't get hold of her. And the second best athlete is the second best sleeper, so it's no coincidence. And actually the athletes that struggle are the ones that are not sleeping properly. They're not embracing the holistic nature of athletics development and stuff like that. So I think, look, sports science is there, the fads are there, some of you enjoy it, fine, no problem, but just be a little bit wary, a little bit careful. I think common sense kind of wins at the end of the day.
Just to, I think one of the really big takeaways for people in the audience is data informed, not data led, is crucial. So I couldn't agree more with that. And the people who are always data led tend to be the people who've never been into a coach's room on a Monday morning when you haven't won for 4 weeks. I think be very careful how you handle the data and just make sure you interpret it in the context of you as a person.
That's a great line. Data informed, not data led. James, when are you going to allow the regular athletes to come and spend a weekend at your high performance?
I've already been harassed by a couple of people
so
here.
We're going to get that
come,
soon.
so it will happen.
Super.
I promise you. It will definitely happen.
So I'm going to direct the last question at Shiva. Shiva, so you've been involved in grooming and identifying talented athletes, which the Reliance Foundation is then supporting and giving, taking care of a lot of their needs and training and everything. So can you tell us a little bit about how that is going and any sneak preview prospects of how the Olympics is going to look for us?
Yeah, no pressure on that question. Well, I think as somebody who's come up as an athlete during a time when there wasn't much of a support system for grooming athletes in our country, it gives me a huge amount of hope for the future, because one of the things that I realized in my journey as an athlete was that you need to get to that stage to be able to measure up against others in the world, and then to get that self-validation, confidence, and the self-belief as a society. So I think Reliance Foundation is leading this from the front. We're investing a lot of money in developing young athletes. We have a huge grassroots program. Of course, we have a high performance and elite program as well. Right now, there's a lot, of course, going on in that top of the pyramid to make sure that our athletes that are good, tend to become the best, break world records. Something that James has been doing with us. However, I think our real potential as a country is, our human capital, right? So how do we involve more people in this story? Because sport, the way we see it at the foundation, yes, performance is important, results are important, but we try to take a holistic view on things. You have to be fulfilled as a person, live a meaningful life, contribute to society, and what sports does, especially if you start it at an early age, and this is something for the parents out there, is that it gives a value system right, that you can really build on. Certain concepts, working hard, discipline, excellence, fair play. So these are things that are really the building blocks of society, which is why I think we are so invested in doing well in sport. Of course, our performance internationally is increasing. It's been the overall trend is quite a big increase because we are traditionally underachievers in the sports field, and we've realized that this is not rocket science. It's fairly straightforward. What makes an athlete successful, barring a few trade secrets, most of this information is available, right? You can study this and you can replicate it, which is why I think sports science is so important, because you make things replicable, right? I know you can always have a genius coach that is tinkering. I used to have one of those, tinker in the sled room, and then suddenly you're going fast the next day, but nobody understands it. But what we are trying to do with the scientific approach is be informed by data, make processes that are then replicable, and then you have a whole army of an entourage basically for the athlete that works on various levels, right? So we have the strength and conditioning, we have the physiotherapy, the nutrition is so important, and especially at a young age, because I think one of the things where we lose out is that we're not getting the right nutrition from a young age. So there's a huge amount of work to do. I'm really honored to be working in this field because of course I'm personally invested in it. Apart from you see the results and you see the effect that you have on young people's lives, and you see these athletes as they grow in their trade, in their sport, you see they turn into leaders in their society and they influence others. So it's just the snowball effect.
Thank you. So it's not rocket science, it's sports science. So being sports people, and we must respect and stick to time. So thank you. We're going to close the panel. Thank you very much. You all have been a fabulous audience. Thank you for your attention. Just a couple of announcements. Mihira has curated a nice heart-friendly and sports-friendly light dinner. So please make sure you all have it before you go home. You can run tomorrow morning at 6 a.m. Don't worry, it's light in calories. So thank you very much. And I'm just going to request Ritika from our marketing team to just hand over quick mementos to our guests, please. Thank you. Thank you, everyone. Please stay back for dinner, and you've been a lovely audience. Thank you.
Hello, my name is Sanjay Sharma. I'm Professor of Cardiology at Cleveland Clinic, London. My interests are in sports cardiology. It was a real pleasure here to be at a joint conference between HR Reliance and Cleveland Clinic. I spoke about the benefits of exercise on the cardiovascular system and explained to the audience that exercise reduces the risk of cardiovascular disease and increases lifespan by 3 to 7 years. I also mentioned that exercise paradoxically can trigger myocardial infarction and sudden cardiac death in some individuals. I talked about methods by which we can identify young athletes using the ECG. I also explained that most deaths, although rare, occur in recreational athletes who are in their middle ages, and in these sort of people we have a pragmatic approach. We normally test individuals who are habitually less active than they should be, those who've got symptoms such as chest pain, breathlessness, exertional dizziness or syncope, and those who've got risk factors for coronary artery disease such as high blood pressure, diabetes, cigarette smoking, or a family history of coronary artery disease. In that subset of middle-aged individuals, we advise an exercise stress test and some other functional imaging to check for coronary artery disease. If these things are not available, what I preached about was education and ready availability for cardiopulmonary resuscitation and application of an automatic external defibrillator, which can improve outcomes by 5-fold.
So we've just wrapped the meeting between the Reliance Clinic and the Reliance Foundation in Cleveland Clinic, London, where I spoke about my philosophy of treating both patients with exercise medicine issues and with musculoskeletal health queries. Really good audience, really good interaction, lots of take-home messages. Largely look at the patient rather than looking at a muscle or looking at a joint. When you use data, be very careful how you interpret it and try to move to being data informed rather than data led. And ultimately we want people to be fitter and healthier, and that's all about encouraging good habits which they can maintain for a long period of time.